We ask you to guide us in our efforts to resolve the many issues confronting our healthcare delivery. We ask your blessing so that we may resolve these issues always for the benefit and welfare of our patients. Impart your supreme wisdom upon our activities today so that our affairs may reach a successful conclusion. Thank you for being our source of guidance. We make our prayer for Christ our Lord. Amen.
Thank you very much, Reverend Father. In this gathering, we are all present for today. We need a chair. And to introduce the chair for the program, let's invite Dr. Sefako Adinyura to do as the honor.
Good morning. So I've been given the privilege and the honor to introduce the chairman for today's program. He is a teacher by profession and an inspector of schools, currently at the Volta Regional Education Office in Ho. He has over 18 years experience in teaching and has taught in basic and senior high schools. He has also instituted an education fund with the help of the Amenyo Foundation in the USA. This fund has seen a lot of needy but brilliant students through their secondary and tertiary educations. He has also championed many developmental projects, such as the construction of kindergarten blocks, building of water systems, finishing of newly built health clinics, and among others, enlisting 1,000 citizens and non-citizens for the National Health Insurance Scheme. His area of expertise is science and has specialized in science education. He is gifted with a spirit of counsel and has helped many people. He's a family man with strong passion for education and religion. He is a friend of the cured lepers in Ho and has championed many social intention projects, such as provision of wheelchairs and crutches, food, clothing, sewing machines, and scholarships for the children of the cured lepers. He has preached the word of God in many churches and has organized crusades in villages, small towns, and cities. He is none other than Togbe Kotoku the 11th, the paramount chief of the Pengwe traditional area and member of the Asogli Traditional Council, to invite the chairperson.
Thank you. This morning, I think I have the blessings of my colleague chiefs and queen from Asogli State. I bring you greetings from Togbe Afede the 14th, the paramount chief of Asogli State, and the president of the National House of Chiefs. He would have loved to be here, but because of an equally important assignment, he has asked me to deputize for him. Taking in the team for the review into account, I think it is just telling us about one thing, that is remembrance. Remembrance. How health and medical issues started. Even before we have the modern day medical practices. You will see that it's talking about caring for everyone and and then learning from everyone. This just reminds me of the traditional way our great-grandfathers used to care for the sick, where the high priest, whenever anybody is sick in the community, the high priest is also sick, in the sense that in most of the medications, even the patients don't take them. It is the high priest who takes the medication and goes through the pain the patient is supposed to go through. And it was all about caring for everyone and also learning for everyone. So it will be good and prudent if what we are about to review concerning the theme, we'll follow it and remember how medication started. Thank you.
Gathered here today, I would like to introduce some of them to us. As more come in, we'll introduce them subsequently. On the high table, I'd like to introduce to you Honorable Charles Agbeve, representing Parliament. He's the MP for Agoti Mesiofi. He's a member of the Health Committee. We have the Vice Chancellor of the VC of UHAS, Professor John Japon. We have the Honorable Minister of the Volta region, Honorable Dr. Archibald Yaolecha. We also have the CEOs of our sister teaching hospitals gathered here amongst us. We have Dr. Daniel Asari, CEO of Kolebu Teaching Hospital. Dr. Eric Kofi Injedu, CEO, Cape Coast Teaching Hospital. Dr. Ohenibo Usu Danso, CEO, Konfanochi Teaching Hospital. Dr. Karim Mumuni, Acting CEO, Tamale Teaching Hospital. We also have the Deputy Director at the Ministry of Health, Mr. Lawrence O. Lawson. Other people gathered amongst us here today, we have the Queen Mother of Hodome, Mama Achato II. We have the King of Hodome, Togbi A.L. Housu XII. We have the King of Hu Ahwe, Togbi Kasa III. We also have the representative of the Dean of the School of Medicine, UHAS, Dr. Eugene Dodoye. We have the Deputy Regional Commander of the Ghana Police Service, ACP Kwesi Akomia Apreku. So we'll continue with our program as more guests come in. We'll continue with the introductions. I'll also do the introduction of our directors subsequently. So next on our item, we'll be taking a song from we'll be taking the anthem from the whole Teaching Hospital choir. Please put your hands together for the choir as they give us the whole Teaching Hospital anthem. Yes.
HTH choir. Thank you very much, HTH choir. To continue the introduction of our dignitaries, we have in our presence the Regional Director of Health Services, Dr. Timothy Lecha. We also have Mrs. Innocentia Ruby Gogbolovo, the Acting Director of Nursing Services, Whole Teaching Hospital. Next on our list, we have our welcome address to be taken from our Acting Chief Executive Officer of the Whole Teaching Hospital. With a round of applause, let's welcome Dr. Tampori.
The representative of the Minister for Health, the MP for Kwetoi Anyingbe, also representing the chairman of the Health Committee of Parliament, and also the ranking member of the Health Committee of Parliament. And he is himself a member of the Health Committee of Parliament. The Regional Director of Ghana Health Service, also representing the Director General of Ghana Health Service. Directors from the Ministry of Health, Togbeo, Mamao, CEOs of the various teaching hospitals of this country, Vice Chancellor and staff of UHAS, invited guests, the media here present, distinguished ladies and gentlemen. I'm supposed to welcome you to this place, but I think that I can only welcome you to this room, but the one to welcome you to the region will speak, and you'll get your proper welcome. All the same, I'm very happy to welcome all of you to this 2019 Annual Performance Review Conference of the Whole Teaching Hospital. I don't know, some people don't agree that it's a teaching hospital, but it is. I have somebody here I will not mention. He says we have 4.5 teaching hospitals, but we indeed have 5. Because it doesn't depend on the age. I know Kolobi will be 100 in the next 3 years. And it doesn't depend on how long you build a maternity ward. It depends on the mandate that you've been given. And I'm particularly pleased that on this occasion, the sector minister has been well represented, the parliamentary committee has been well represented, my colleague chief executives well represented, Ghana Health Service well represented, and obviously the government and the traditional leaders, and also our partners in health development, UHAS. We are most grateful for your presence because it affords us the opportunity to to learn from each other in our shared quest to improve healthcare delivery in the country. I'm particularly glad that apart from being peer-reviewed on the corporate performance of the teaching hospital, it will also offer us the opportunity to fine-tune our strategies for addressing some of the challenges confronting us as an institution after the status of our facility changed from a regional hospital to a teaching hospital. And we are just 10 months old. We'll soon be a year. In April 2019, the Volta Regional Hospital was rebirthed into Ho Teaching Hospital. Its legal mandate, just like other teaching hospitals, is to provide specialist care, training of undergraduate and postgraduate health professionals, and conduct medical research to address emerging health problems of Ghana, including coronavirus. The vision of management of the hospital is to make it the premium innovative tertiary health care, medical education and research center. The catchment areas of the hospital have also increased. Apart from the district's health facilities in the Volta and Oti regions, it also extends to the eastern region and some neighboring countries like Togo and Benin. Ladies and gentlemen, the theme for the performance review is setting the agenda for innovative tertiary care, caring for everyone, learning from everyone. It is obvious that for every episode of care delivered to clients visiting the Ho Teaching Hospital, there are lessons to be learned from the services provided. Every encounter with a client leaves a footstep to be traced. And when these footsteps are appropriately traced, they unravel exactly how the clients want to be treated. It also explains how well or how badly we cared for them. As the latest teaching hospital, we have put in place certain solid strategies and measures to propel us to achieve our vision. So it's not always a disadvantage to be last, to be born last. There are so many advantages. And the advantages are that you don't learn from the mistakes of the senior ones. You polish them up and make sure that they are not repeated. I believe our core values of commitment, accountability, dedication, integrity, professionalism, innovation, teamwork, and safe care will motivate us enough in achieving this vision. I'm happy to inform you that this conference is being streamed live on various social media platforms like YouTube, Facebook, Instagram, and Twitter, including our very own website, www.ath.gov.gh. This obviously doesn't make us last. I think that it tells us that there are certain things that we can do differently, and when properly done, can give you the basis for further development. As far as governance is concerned, 7 directorates have been created to lead the implementation of our strategic direction. These are medical, pharmacy, administration, human resource, finance, nursing, and research. Research, planning, monitoring, and evaluation. Distinguished ladies and gentlemen, we are also at the advanced stage in the creation of sub-BMCs, which will help enhance the quality of work, decentralize decision-making, and effectively and efficiently manage the various cost centers associated with the provision of quality healthcare delivery. I wish to indicate that my administration, with the support of a board when constituted and inaugurated, will pursue other innovative programs and policies that will bring robust transformation in the healthcare delivery to our cherished clientele. Ladies and gentlemen, in line with the proverbial adage that an examined life is not worth it. An unexamined life is not worth living. It is on this premise that we have assembled here to assess our performance for the year 2019. Since 2016, OPD attendance has seen a steady increase. The year under review, that is 2019, OPD attendance increased by 2.69% from 159,866 to 164,173. Admission at the emergency department increased by 18.14%, resulting in an increase in the bed occupancy rate from 65.3% to 88.7%. This means that a bed in the emergency unit services 130 patients, or serviced 130 patients each bed in 2019, as against 113 patients in 2018. This trend is really putting pressure on the emergency department and requires immediate attention. Regarding institutional maternal mortality, there has been an increase from 856.5 per 100,000 live births to 1,064.9 per 100,000 live births. Unfortunately, these were Ghanaian lives. What could have been done differently to avoid this? If you disaggregate the data, 19 out of the 20 were referred from peripheral facilities. That means that we have a lot of work in cooperation with the Ghana Health Service to see how we can strengthen the peripheral facilities to reduce this burden on our population. And due to the nature of the roads, obviously, there are delays in reaching the hospital for emergency interventions. The hospital is exploring ways to use ICT to intervene in some of these cases. We hope that we'll be able to use facilities such as video conferencing and other mobile applications to mentor our referring facilities. Institutional neonatal mortality rate also followed a similar situation. Stillbirth rates also increased marginally from 25.3% to 26.1%. This, we believe, if the necessary interventions are put in place, we'll be able to control. Diagnostic services increased in the year under review. For example, laboratory services increased by 5.18%. However, all the tests requested were not done due to lack of some equipment. In view of this, the hospital went into agreement with MDS Lancet to help bridge the gap in our quest to increase access to these services. Imaging services are also on the increase. For example, X-ray services increased by 17.96%. Going forward, the hospital intends to increase its investment into additional diagnostic equipment, such as echocardiogram, ultrasound, and endoscopic equipment to augment the existing diagnostic services. We are also collaborating with the Ministry of Health to facilitate the refurbishment of our defunct MRI machine and possibly the acquisition of a CT scanner to help our clinicians diagnose appropriately and obviously treat. Ladies and gentlemen, it is refreshing to know that the hospital, in her quest to ensure privacy, continuity of care, and easy access to services, and ensure prompt processing of NHIS claims. Invested a lot in acquiring fiber optic network to ensure smooth running of our applications. This has also facilitated proper monitoring of our finances through interfacing the hospital administration and management system with the National Investment Bank financial system for collection of cash. This ensures that monies paid by patients are channeled to the appropriate bank account in real time. Regarding hospital information management, the hospital acquired additional computers and Surface Pro to fully go folderless next week. And when we mean currently what goes on is that the OPD is completely folderless, but the inpatients and theater will use folders. And next week, that will be a thing of the past. Everything has taken place. Training of users is ongoing. The hospital already has over 150 desktop computers, about 23 laptops, and 3 servers developed in various stages to do this. So X-ray services, you will only print when you need. Otherwise, everything will be on the computer, ultrasound and all that. So we virtually will not need paper to work with. In the year under review, security has become very critical. And to beef up security in the hospitals, you know, the government actually is not employing the category D any longer. And the few that we have are quite aged. And to replace them means that you have to use your IGF, but there are limitations in the use of this money. So that means that you have to be a bit innovative. So we set up close to 40 CCTV cameras all around the hospital from the entrance to the mortuary. And so in real time, we are able to see everything that is happening there. And there have been very interesting results. People forget and take something small. On the way, the security said, you took this, it's not yours, go and put it back. And we are watching. And it's done. So this is helping. The only difficulty we have here is that the psychological medicine area, we haven't been able to enter the wards, and that is our next plan. So that the nurses sitting will see all that is happening in the rooms, because some are suicidal, and if you don't monitor them properly, it can result in uncomfortable results. We also constructed a cardiothoracic unit for babies and adults at a cost of 175,833 cedis, 78 pesos. We have been criticized as to why you have to do that. You see, the hospital is not standing on its own. It's also standing with the university. The university has plans, and the hospital has to join and then, support to make these plans work. And so the hospital and the university together in their plan felt that there was a need for something like that. So we collaborated and did that. That apart, information from cardio in Kolebu tells us that about 25% of the clients who visit, they actually our people from the Volta region. So that means that there is the need for such a facility, and that necessitated that. The university has provided the human resource necessary and is planning to support even with equipment. The hospital has put up the structure and is trying to also help bring in equipment. I'm happy to announce to you that going folderless started in the year 2019, and the latest will be next week, and I mean next week, not something else. Okay. Distinguished ladies and gentlemen, permit me to state that The hospital beefed up its equipment base by spending an amount of 435,528 cedis from our internally generated funds. And this was to procure equipment to help improve quality of service. Among the equipment procured were dental chairs, patient monitors, X-ray viewers, a ventilator, because we had 2 ventilators donated by the ministry last year. Well, that is 2019. We also bought diatemy machines. And as for air conditioners, they are becoming the order of the day. It's scary, the number of air conditioners we are hanging around. To enhance the human resource capacity, which is the driving tool for transformation of the hospital, we incurred a total of 65,355 in 2019, as against 58,015 cedis in 2018 from our IGF on staff pursuing various programs and specialties in Ghana and beyond. This obviously excludes the training of doctors, which have been taken over by government since last year, and we are very grateful for this initiative. Staff accommodation. The hospitals incurred a cost of 143,884 cedis, 25 pesos, on provision of decent residential accommodation for staff, as against 84,329 cedis, 35 pesos, with the internally generated fund in 2018. This is very important for the motivation of staff to give their best. Obviously, as young as we are, the challenges, I can't say all, but I'll mention a few. So the major challenges confronting the hospital include inadequate specialists. And if I give you the breakdown, which will be done, you see that majority of the specialists that we have were actually employed by the university. We obviously have inadequate accommodation for the service delivery, both residential and clinical. And we have inadequate vehicles. Should I say inadequate? We virtually have no vehicles. Because the youngest vehicle the youngest vehicles we have are 2 pickups, which are 6 years old. Elsewhere, they should have been written off. But that's what we have, and that's what we are working with. Dr. Chairman, ladies and gentlemen, in the midst of all these challenges, management has enjoyed full support from the sector minister, the regional minister, UHAS, the traditional leaders, and obviously the community at large. Once again, you are welcome, and we appreciate your contributions during this review to enable us improve upon our services as pursue this agenda of caring for everyone, learning from everyone is concerned. We are poised to improve in all spheres of our activities in the coming years. Our goal is to develop a medical center of excellence instead of departments. I believe with the support of government, this board, the board and all major stakeholders, we shall get there. No, remember I mentioned that one we are working. I particularly wish to urge all the units and directorates to continue to be the best that they can to further lift their performance to enhance the quality of services to our clients and the fortunes of the hospital. Finally, may I commend again the staff of the various professional groups for their continued support throughout the year. My humble appeal to you all in this regard and we hope that you continue to help assiduously. In fact, I need to acknowledge the support that my colleague CEOs have also given. In terms of staff, wherever they had what they thought was excess, they always called us and then pushed them to us. And this has been very phenomenal. And I hope that that support will continue to come. So thank you very much, and I wish you a very wonderful interaction. And we hope that at the end of the day, Ghana will be the winner. Thank you.
Thank you very much. Can we put our hands together once more for the acting CEO of the whole teaching hospital? Before we continue with the next item on the list, I want to make some more introductions. First of all, we have Dr. Stephen Lai. He's the acting director of medical affairs of the Cape Coast Teaching Hospital. Dr. Abbas Adam, director of medical affairs, Tamale Teaching Hospital. Dr. Senak Beglu, the registrar, University of Health and Allied Sciences. Professor Ernestina Donko, acting dean, School of Nursing, UHAS. Professor Francis Zoto, dean, School of Public Health, UHAS. Is this Zoto? And then we have Honorable Prosper Kofi P. Bansa, the MCE of Home Municipality. We also have Professor Eric Ofori, Dean, School of Allied Health Sciences, UHAS. Mr. Samuel Akotua, Director, HR, Kolebu. We also have amongst us the Flying Officer Dominic Anaman. He's the representative of the Station Medical Officer of the 66th Artillery Regiment. Further introductions will follow suit. As our CEO rightly mentioned, we are streaming live on YouTube, Facebook Live. So you can go onto Facebook or YouTube, search for Whole Teaching Hospital, and you'll find us streaming live. We'll be taking solidarity messages from our sister teaching hospitals and also from the Regional Health Directorate. So first of all, let's put our hands together as we invite a representative from the Regional Health Directorate to give us a solidarity message. Please put your hands together for Dr. Lecha. Regional Director, sorry.
Thank you very much, MC. Tagwe Chairman, Honorable Regional Minister, the representative of the Minister of Health, my Honorable MP Agotimes Jofe, Vice Chancellor of the University of Health and Allied Sciences, all Chief Executive Officers of our teaching hospitals, including the Whole Teaching Hospital, Tagweo, Mamao, distinguished invited guests, colleague health workers, ladies and gentlemen, I am delighted to be part of this annual performance review conference of the Whole Teaching Hospital. I must say that the Ghana Health Service and the teaching hospitals are agencies under the Ministry of Health. And since we have the same father, our challenges, I believe, are similar. I was particularly happy when the regional hospital who became a teaching hospital, even though that meant that my powers were being curtailed. And to worsen this further was the creation of the OT region, which meant further reduction in my influence. However, we at the Ghana Health Service and the Regional Health Directorate will continue to collaborate with the newest teaching hospital and offer our support to them whenever we are called to do that. We will share our experiences with the management and offer advice whenever necessary. It is said that the mark of a good leader or leadership is the one that is able to identify the obstacles and then overcome them to be able to achieve their results or the mandate for which they've been established. We congratulate the management and staff of the whole teaching hospital for coming this far. We wish you a successful conference. Thank you very much.
Thank you, Dr. Lecha. We'll take the address by the guest of honor and then we'll continue subsequently with the solidarity messages. So please, with a hand of applause, let's welcome the Regional Minister, Honorable Dr. Archibald Lecha. Please put your hands together for him.
Thank you, MC, for allowing me to jump the queue. I said in the land of the sick, he who jumps the queue dies first, but I will not die first. And I believe that those of you who don't know the difference between the regional director and myself would get to know today. So when you see him in Agbenokevi, it's not me. Togwe Chairman, the acting CEO of Whole Technical, Whole Teaching Hospital, and CEOs from other teaching hospitals of our dear country, Honorable Member of Parliament, representing the Health Committee, Honorable MCE. Because I'm on Asogliland, I'll mention Togbe Kasa, because I live in Ahoy, to be safe. Mama Atrato and all other Togbe Hosu and all other chiefs of Asogli. Togbe Mama, Vice Chancellor, and management and staff of UHAS, management and staff of the whole teaching hospital, regional. It's an honor done me to be invited to be the guest of honor. And it wasn't easy for me to come, but I feel it's an obligation for me to be here today. Whole Teaching Hospital is such an important institution to us in the Volta region, and we shall continue to support you in all that you do. We know that you're working under very trying conditions, and I receive many complaints about you, and I know that is the rule of the game. And some of them over-exaggerated, and many of whom, when investigated, are found to be untrue. I would like you to continue doing your best to serve the people of this region and the people of Ghana. I admire the way the acting CEO
try to involve the community in all the activities of the hospital. Because the acting CEO is part and parcel of the Volta region, except that when he is on leave, he remembers the Upper West region. And when on leave, he cannot even leave the knife alone. He has to, my colleague from Upper West has to call me that, oh, your doctor is here, oh, he's so pretty. The theme is very relevant, setting the agenda for innovative tertiary healthcare, caring for everyone and learning for everyone. I agree with this, and I think that our focus is the people of Ghana and all those who live within the boundaries of our country. And this is the newest tertiary hospital in our country, and therefore we are not going to make the mistakes that others have done, because things have changed. I remember when we were in Kolebu, there was only one computer in the hospital. And that computer filled one room. That's a mainframe computer. So we only passed by, they said the computer is in this room. Now the CEO mentioned many computers in the teaching hospital. So because of technology, we have an advantage to perform better than those who were before us. So this hospital, we expect, should be the best teaching hospital in West Africa. But that also means that government has to bring the cash. Is that also? And the facilities to have to improve. And it also means that we should be able to attract the qualified people to come and be prepared to work among us here. That means that Tokbeo and Mamao must continue to talk to our people to change their attitude to public servants who come to work here. Because there are our own people who are our children who decline to come here. So if they are given the choice to choose, those on my right side will take more from us than ourselves. I mean our own people, citizens of the Volta region who are health professionals. If they are to choose where to work, they will be choosing, I think the first choice will be Kubasi, second choice will be Kolebu, third choice will be Cape Coast. Sometimes it's because of the attitude of our people. There's a doctor who worked here once who called me that a patient flashed him at night. And when he called back, he said, oh, doctor, I don't have credit. So please call me. Let me tell you what is wrong with me. I remember there was once, I happened to be, for those of you who don't know, I'm a doctor too. I happened to be asleep about 2 a.m. struggling to sleep. Then somebody called me, doctor, I can't sleep. What can I do? So because he cannot sleep, he woke me up at 2 a.m. I must say that I admire the determination of the management of the whole teaching hospital. And I know Mama Trato is part of the hospital. Dr. Tabo, is that not true? And she's the mother of whole teaching hospital. And I would have wished to be here throughout the review. But unfortunately, because of other challenges, including security. So, I say, police, can I ask permission for you to? We have a challenge. We want to keep the highway open so that those of you who travel to Aplau or to Accra to Sogakope can have safe passage. So, We wish on behalf of the Volta Regional Community Council and the chiefs and people of the region, I welcome our special guests from Accra and the other parts of the country. And I welcome all of you. And you are safe. Don't be worried about security at all. Have a good time. And I believe that at the end of the day, whole teaching hospital would have learned a lot from the review. It's not about finding faults. It's about helping us to improve on our services. Because the patients are the center of what we do. So we'll learn. Our colleagues will also learn from us. Because there are certain things that we are also doing that they are not doing. But we would also learn from them. So that together there will be mutual progress made by all our institutions. With that, I'll sit for a while. I'll listen to a few solidarity messages, and then I will disappear. I wish you all the best. Thank you.
Oh, please do it better for the Honorable Minister. We'll continue the program. We'll take another message from Parliament. So let's put our hands together for the Honorable MP Charles Agbeve.
Thank you very much, MC. Togwi Chairman, the Honorable Regional Minister, Dr. Archibald Lecture, the Vice Chancellor of UHAS and his staff present, the acting CEO of Who Teaching Hospital, the hard-working staff of the Ghana Health Service present, ladies and gentlemen. In fact, I'm in a very difficult situation here because I was called by my ranking member, Honorable Kobna Minta Kando, Charles, go and represent me in Who. Once I was descending the stairs, then I met the chairman of the committee, Honorable Nuama, Dr. Nuama. Charles, I want you to go and represent us, the committee at Who. And I'm like, so I'm representing the minority and I'm representing the majority. As if that is not enough, then I get a call for Honorable Bejra, the chairman for the voter caucus. Charles, understand you are going to Who to represent the health committee, represent the caucus. So I find myself representing 3, and I don't even know which one's message to present. But being a citizen of the region and hailing from a constituency within the region, I think I find it appropriate to represent these 3 institutions or 3 personalities. The Select Committee of Health ushered in its newest baby, which makes it the 23rd department or agency under the Select Committee, and that's the Who Teaching Hospital. And for the first time, they presented their budget to us. And we realized that they went for serious training from their colleagues before they came. Because before you meet the committee, even his colleagues here will tell you, we don't look at the face again. When you get there, we are no more friends. We have to do our oversight duty, so we'll do it. But I must admit, the teaching hospital is doing its best. I'm privy to some information you'll be presented to today, because before they present their budget, they must tell us the state of affairs. And I must admit, the reason why these people selected me was when Whole Teaching Hospital presented their budget, I became emotional. In fact, the members who were there will tell you, I went ballistic. Because there was a very important element they presented, and it worried me. They had told us at that time that 1,340-something deaths was recorded. That was between January to September. And it was quite alarming. So you can understand why I became emotional. Because most of those deaths came from my constituency. And the reason is very simple. Our people wait, and when the situation becomes very bad, then they refer. Sometimes they wait, and when they get to the health center, it's so bad that the health center cannot do anything than to refer. And when they get to the teaching hospital, there's nothing they can do. So then it becomes the record for the teaching hospital. And it is very, very common. When you go to Kolebu, Konfanochi, Kekos, it's the same thing. And that was when some of us became very, very passionate and emotional. But I think there's a way out. And Dr. Tampori and his team really have been doing their best. I think I've seen Dr. Tampori sit in a health center in my constituency treating patients. And that is what we are looking for. And we thank you so much for extending that service to the grassroots. At the committee, we identify challenges. And not with only whole teaching hospitals, with all the teaching hospitals. The challenges are with infrastructure. The challenges are with health financing, especially that from health insurance. The challenges are with staffing. I'll just give you one statistic. The doctors in this country, we have 52% of our doctors only in Accra. A majority are found in Kolebu. Kolebu? Yes, 52% of our trained doctors in this country are found in Accra. And out of the 52%, majority, Kolebu is holding them. Then, the 18% of the doctors, the rest, are found in Kumasi. The rest are in Konfanochi. So you have 30%. Now we have how many regions? 16. So we have 30% of doctors left spread across the 14 regions. It's a very, very serious phenomenon. And I'll tell you, the reasons are not far-fetched. We saw it. Simple. The doctors are now going for further studies. So where is the physician and surgeons located? Accra. So in order to get further studies, they will go there. We are, as a committee, think we need to decentralize this training. And we are very happy with UHAS and the other teaching hospitals and the other institutions. We could decentralize this specialization so that the doctors could come to these areas and train whilst practicing. And that's why I'm not surprised that Dr. Tampori mentioned that they don't have specialists, enough specialists in the hospital. I'm not surprised. And if nothing is done about it, it will be worse. Because another thing that is attracting the doctors to Accra is, they say we shouldn't say it, locum. Am I lying? It's locum. And locum is in abundance in Accra. So it will take a lot of innovation, initiatives, and motivation to keep our doctors. But I believe we will get there. Dr. Chairman, in the face of these challenges, the hospitals need to be innovative. They need to be creative because funds are not enough. The budget approved for us this year for the health sector was a little below 6 billion cedis. And that was mainly for compensation and some minimal amount of goods and services. CAPEX was virtually zero because we're going to rely on donor funding for CAPEX. So it means the hospitals must look at other sources of funding to be able to maintain the care and health deliveries they want to give, best quality they want to give the citizens of this country. And it's in this direction that I want to applaud all of them. And please, I know there are some district directors of health, rural health directors here. Specialized care is expensive and cannot be taken out by health insurance. And as such, we need to start educating our people that when you are holding health insurance and entering the teaching hospital, you must be ready to pay something. I mean, just this morning, we need to. If we don't, we will collapse our health delivery system. And I work with health insurance. I'm a damn socialist, and I would have wished everything should be free. I'm a very, very devout socialist. But when it comes to health care, I've got to learn that it is not cheap. It's very expensive. And we need to rather find other alternative means of supporting the poor and vulnerable. Once our social health systems are improved and we can identify that these people coming are really, really poor, then the hospital can assist and see how we can get healthcare delivery to the poor and needy. I must commend the hospital for going very, very digital and in this IT age. I'm praying that with these innovations they are coming up with in technology, we could see how they could start some form of telemedicine where they will sit in home and guide our midwives, guide our doctors at the various districts to carry out very simple operations and avoid the traffic of moving from the districts to the hospitals or the health center, the teaching hospital in Ho. I must admit, in my own constituency, specifically Shopping Health Center, when a midwife refers a pregnant woman to Ho, the bus stop is a mango tree in front of the hospital. She doesn't see why the midwife cannot deliver her. They hold our health workers in high esteem. And there's need to educate them that when we refer you, it's not that we are punishing you, but we are asking you to get the best health care. And that education should go on well. And if we are not able to do that, then the conditions what we are having now where the death rates are high will continue. I'm also going to commend you for taking a very good theme, caring for everyone, learning from everyone. It's a very good theme. I intend sitting in to take part in the whole proceedings and take a very good report back to Accra. We, the committee, will be looking at you as our newest baby. The old ones, please don't get jealous. They are our newest baby, and we need to help them grow. And we will do all we can to assist you with your needs. At this juncture, I thank you very much for the opportunity.
Thank you very much. Togbe Chairman, permit me to stand on existing protocols so that we can move very quickly. I just want to say that UHAS sees itself as a very important partner with the whole teaching hospital. That is the very reason why we, if I may use political language, we were with you in the trenches in ensuring that the birth of the teaching hospital came into fruition. And since then, we have been there with you. I believe we all know and acknowledge that there is a teaching hospital because of UHAS. Without UHAS, there will be no need for a teaching hospital. And for that reason, we see it as very, very important. And we are in this business together. We would work with you very closely, and whatever programs that you put in place, we would collaborate with you to the best of our ability to ensure that the right things are done. I would wish that Honorable Member of Parliament representing all the three groupings would be this passionate about us forever. I say this because when Dr. Tampuri will tell you, when we presented our first budget for getting the teaching hospital underway, it wasn't very easy, and they were sliced from all kinds of corners, and even what was promised, we didn't even manage to access it, and we need you to be able to go through this whole journey. We will work with you very closely, and that is the reason why we are ensuring that the critical human resources that are available to make it a teaching hospital are available. We know we do not have enough, but at least the scene is changing gradually. Because of us, now we have a resident psychiatrist who has interns working with him, so for which reason certain referrals are not necessary. We have a professor of internal medicine with us now, and for which reason some referrals are not necessarily taking place. We have a professor of obstetrics and gynecology around with us, who is also working with the team to ensure that certain critical services are delivered. And of course, we have our professors of surgery, some of whom have specialized in cardiothoracic surgery. And we've been hammering on this for a very long while. We have two of the best cardiothoracic surgeons in the country here in Home. The unfortunate thing, and I said this during the inauguration of the teaching hospital, the unfortunate thing is that even though UHAS and the hospital have managed to put together a facility where the patients can be examined and all that, our theater is not fit for purpose. So they see the patients here and then take them to Kolebu to go and operate. So they are shuttling between Ho and Kolebu. All we need is some very basic equipment, which costs very little money in the context of all the monies that we spend all over the place. With only $1 million, we can refit the, you say, hey, what is $1 million? 5 million CDs. How does that fit in the whole context of our health sector? And this can be a very important component of our cardiothoracic services, so that the whole of the Eastern Corridor, I mean, everybody could be here. But we've been running all around for 2 years now. The cardiothoracic surgeons are on our payroll, but they operate in Kolebu. We will continue to work with you, but we need all the forces to galvanize, to ensure that there is gravitation, and then the resources are put to where they are needed. Here we would need our parliamentarians, our government in particular, our chiefs and elders to push and get these things done, so that the people of this community will benefit from the services. On that note, I want to thank you so much for this opportunity.
Thank you very much, Prof. Back to the teaching hospitals. Let's put our hands together as we invite Dr. Eric Injedu, the CEO of Cape Coast Teaching Hospital. Please put your hands together for him as he comes.
Mr. Chairman, I would like to stand on the protocol already established to deliver this short solidarity message on behalf of the Cape Coast Teaching Hospital I bring you greetings from my board chairman, Nana Ehunabobrin Prajin Sim the 6th, who has expressed that he was not invited, and so hopes to be invited next year to the performance review. And for those teaching hospitals that have not invited yet, and went to the wise, is in hope. For me, it's a great pleasure to be here once again, the third time in 10 months. I think that it takes a teaching hospital that is desirous in progressing fast to be able to assemble the CEOs of the teaching hospitals 3 times in 10 months. When we were called to this review, we wondered what we were going to review because you are not even 1 year old. And you have called it annual performance review. So we don't know whether the year now is 10 months. But it is telling us a story that whole is moving very, very, very fast. I want to commend our colleague, Dr. Tampori, and his management team for the way they have managed the transition of the regional hospital to a teaching hospital. We have been there before, and my mentor, a very experienced and seasoned, the most seasoned health manager in Ghana, had the opportunity to drive that bus. It is in that respect that we all came together to support Hope because we thought that we had very seasoned colleagues who could help drive your agenda. The theme you have chosen for us offers you the opportunity to do an introspection. At this stage, you don't talk about failures. You're going to talk about opportunities that are available to you. You're going to review your processes. And you're going to talk about challenges. But most importantly, you're going to talk about innovations that will help drive or set the agenda for the things that you want to do in your strategic plan in the coming years. We as Cape Coast Teaching Hospital have been associated with your progress ever since we started the transition. And I was very excited that Ho became our assessor just last week in the holistic assessment of teaching hospitals. The team was led by the Director of Administration, Simon Jokoto, and we're excited about the way they took the objectives of the holistic assessment and then assessed Cape Coast Teaching Hospital. So we don't take it that Ho is the last one. We think that Ho, after 10 months, now have at least 4 incisors. So they cannot continue to suck their breast, or they will bite. So ladies and gentlemen, we think that many private medical hospitals are coming up. We hear in the news government contracting loans for the construction of teaching hospitals in Koforidua, Sunyani, and the rest. So we want to challenge Ho to begin to say that they are not last teaching hospital. They just are going to be overthrown by many that are yet to come. And it will be very unfortunate to see any of those that are coming overtake Ho after being born premature. So ladies and gentlemen, Cape Coast Teaching Hospital is very happy to be associated with your progress and will continue to offer the necessary support in all areas that we can, and then ensure that we also learn from your innovations so that collectively we can grow the teaching hospitals in Ghana. I am not here alone. I'm here with my acting medical director and the person of Dr. Stephen Lai. And I also came with my health information manager purposely to come and learn in the person of Mr. Robert Girapa. On that note, Toby Chairman, I would like to ask your permission to hand over to my other colleagues.
Thank you very much, Dr. Njedu. Coincidentally, Dr. Njedu was in Cape Coast when I was a student at the Cape Coast School of Medical Sciences. At that time, the next speaker, Dr. Asare, was the CEO of the Cape Coast Teaching Hospital. Please put your hands together for Dr. Sari, the current CEO of Kolebu Teaching Hospital.
Good morning and greetings from Grandfather Kolebu. Togwe Chairperson, Honorable Regional Minister, my friend MP, Vice Chancellor, staff of whole teaching hospital, the regional director and staff and cherished staff of the newest teaching hospital, and my own friend CEO, newest acting CEO. I don't envy you at all because this is a very, very dangerous position. Very dangerous position. If you see my friends here, when we started off reviewing ourselves, we were all different. Now there's a different set of CEOs. Remember there were the Gilberts, there was Cambon, they go, the changing over is like the MPs. So it's not an enviable position. People will talk about you, but be steadfast, just like the minister has given you all the support. I bring you felicitations from Kolebu, and I came with the Director of Human Resource, Director Samuel Akutia. I know people will say that we hold all the human resource. That will make who what is so. I brought him for networking. Whatever you require and your gap analysis, let us know from him, and the regional minister will support. 80% of all the doctors sitting here, from this table across here, are all Kolebu products. And almost 30, Dr. Karim, the new one, was the ONG specialist for consultant. We had to give him up to head Tamale. So we are grandfather, and our grandmother has always been the Ghana Health Service. Because me, myself, I'm a product of Ghana Health Service, transiting to teaching hospital. So we collaborate a lot. I want to dwell on two things that have been part of the transition of WHO to his present day. In 1999, I came here as a medical director from the newly built, the third of the 3 teaching hospitals that was built by His Excellency J.J. Rowling. I was then the medical director, Dr. Nyamiame. I had to come and study Dr. Nyamiame and see the hospital before we moved to Sunyan Regional Hospital, the new one. That time I was the medical director. Then in 2014, Dr. Tampori had to come to Cape Coast to understudy how to become a teaching hospital. But at that time, I was the chief executive for Cape Coast Teaching Hospital. And last year, we also came here to support the process of moving whole teaching hospital to the current state. And I'm here today, my present capacity as CEO of Kolebu, to come and support. So we have moved around, and I've been part of the transition. And anything we have to do to make this newest teaching hospital work, our door is open. The Vice Chancellor has been part and parcel of it. We talk. The Parliamentary Select Committee on Health, we talk. The 2 cardiothoracic surgeons actually were given to who by Kolebu during my time. I want to do more. Kolebu is 98 years old. In 2 years, it will be 100. So we ourselves want to move to super tertiary and quaternary services. Because when you are there and the only teaching hospital, teaching everybody, producing all this for the last 100 years. What you are talking about Goggi's best time, before independence, through independence, then through all the coups. So now Ghana be your age. You need to diversify and try to move to another tempo. So I'll tell you that currently we still train about 60 to 70% of all the specialists for West Africa. But we'll give special emphasis to the less endowed areas like Ho. we ourselves have now moved into subspecialty training. And now Kolebu is doing robotic surgery. We are doing kidney transplant, cardiac bypass, stenting, brain clots. We don't normally don't open the brain again. You can put the stent through your thigh and remove it without opening your brain. We are able to detach hands that have been severed off, and people still go back to work. The eye center in Kolebu currently declared at the Innovation Summit we did. There's no eye disease in this country that cannot be treated in Kolebu. That no one needs to go outside the country for any eye disease. So we are old, but we are also modernizing. I want to also tell you that if you think you are young and you are modern, you may be mistaken. Oh yes, because Kolebu currently, the polyclinic is paperless since last year, August. Electronic medical records. And the whole Kolebu by June will be paperless. And that is a 2,500 bed. So you are 350 or 400 bed. You should do it tomorrow. You should just do it tomorrow. Anyway, just like I said, the theme is all what I've said. We came to learn, and we also came to give up. Your situation is not going to be better throughout. It's going to be worse before it gets better. Your maternal mortality is going to go up because teaching hospitals, institutional maternal mortality are always worse. Because everybody thinks that when you go there, you survive. But the irony of the situation is that if you are not prepared and they come, now you are telling them they refer late. If they refer early, are you there? Are you capable of saving them? That's where you need to position yourself very well. I was discussing with Dr. Tempori, I'm saying that, I kept saying that technology have come to save mothers. Gone are the days where in Ghana we say that we target only the people who are at risk of dying. Now we monitor everybody because you don't know when the person become risky. So now monitoring devices have been now become the model where every mother and the child must be monitored and be viewed constantly within 24 hours before they deliver. So I've told that we have procured some, and some of them have been donated to a brand new cardiotogograph to video distance. But next month we'll be sending 5 to them to reduce their to train again. So in our own small way, we'll help. My advice to you, and then that if you think that there's a budget coming from government, forget about it. I've been around for 27 years, and I've managed with IGF. And government only pays your salary. When I was appointed 1.5 years ago, Kolebu didn't have MRI, CT because they were not working. But now we have 3 cities, all of them working, because we brought in private provider as a partnership. Once there's a private person involved, the thing will not spoil. But one is a pure public, 100%, it will spoil. I'm telling you, because across Kolebu, there are private people there who, when you send the 20%, you get cashback. So they will spoil it. So go into partnership with people, because people thought that put your money in the hospital, you won't get it back. Let them understand that now you can partner with us and get your money back within 2 years. So the CT we have now, within 2 years, we'll pay it off, and the investor can give it to us, or we'll go into another sharing. So we get 30%, they get 70. As 2 years time, we'll get 60, they'll get 40. Because the load is growing. We are even acquiring PET CT, and the whole West Africa, even Nigeria doesn't have, to detect the minute cancer. So that people, now we send people to UK just for the diagnosis of the primary source of cancer, and it fly back for us to treat. But we don't have money. $5 million, $5 million to $7 million. A private provider said, I have that money. Give me a place, I'll give you 20%, 30%. After 10 years, It's yours. Why don't you have a board, you have a vice chancellor, you have a regional minister, you call them, they go into partnership, and it benefits everybody. Then you have it, and become the source of medical tourism. With all this thing, I think we'll be discussing more. I'll thank you very much for hearing me.
Thank you very much, Dr. Asari. Ladies and gentlemen, please put your hands together for the CEO of Konfanoche Teaching Hospital. Please put your hands together for the CEO of Konfanoche Teaching Hospital, Dr. Ohenibo Owusu Danso. Oh, please put your hands together for him.
Thank you very much, Mr. MC. Toga Chairman and my brother, Regional Minister, other chiefs here, Tobe from the Volta region, and let me especially mention my newly identified mother, Mama Atrato, who's become a very good mother and a special friend. I bring you special greetings from His Majesty. We from that part of this country, we greet very specially, so you must understand me. And I think Togo understands very well. Thank you very much. The Honorable Member of Parliament, a member of the Health Committee, who we know very well and we're working together. I think last year we were all together in Geneva. And I'm happy for the way he spoke. He's actually speaking for the health sector. Colleagues, Regional Director of Health Services, Vice Chancellor, who are my seniors, fellow CEOs, and especially acting CEO of the whole teaching hospital, directors from the Ministry of Health and the whole teaching hospital, various managers assisting the acting CEO at the whole teaching hospital, health staff, media. I'm very privileged to deliver this fraternal message on behalf of Konfanoche Teaching Hospital. And let me begin by saying that I share in your history the whole teaching hospital, because I know where we have come from an ordinary central or regional hospital in Kumasi, and now the second largest hospital and also second to Kolebu as far as teaching hospitals in Ghana are concerned. I'm sure the Vice Chancellor will tell you, we all know the history, where we began from, because we were all educated together in the Kwame Nkrumah University of Science and Technology. And for me, the opportunity of turning into a teaching hospital, no matter the challenges, must be grabbed with both hands, because the transformation is going to be tremendous, and you certainly need it. Because as has been indicated, especially even by the regional minister, your services are going to transform extensively. Your theme, which is setting the agenda for innovative tertiary care, caring for everyone, learning from everyone, is very, very apt. Because as we are all aware, globally, we've all adopted the universal health coverage, and Ghana has signed to it. We are a partner. For Ghana is even very innovative in trying to do much more than the coverage that the WHO defines under the UHC concept. In this, your challenge, as captured by your theme, is very apt because you are wishing to care for everyone. And as we have indicated, we need to have a very robust health system to be able to provide very robust and quality care for our citizenry. And here, I mean the citizens around the whole teaching hospital, more closely in the Volta region. In terms of the teaching hospitals and the challenges that has been spoken about earlier, I think my brother is no more here. I can't find him, Dr. Tampuli. As has been indicated in the earlier speeches, in positioning yourself as a teaching hospital, do not be expecting funding from central government. We have to be very innovative, And being innovative, financing must be very, very key. How we do it is where we are going to share ideas together. Clearly, it's about services, but that's what we are there for. The teaching hospitals have 3 key mandates: provision of service, training, and research. But for us, the research and training should be able to transform or translate into expanding our services. And I'm happy that even under 1 year old, you have already begun to expand your scope, even as your scope, as you begin to think about cardiothoracic and other specialized services, which we are already providing. Because if you look at our financials currently, you will see that most of the internal generated fund that we are getting, which for me is a core of funding all the activities we have, are coming from those specialized service areas which are currently not covered by the National Health Insurance Scheme. And as a teaching hospital, for staff motivation, for financing of your projects, whether it is civil works, equipment, maintenance, what have you, you are going to be highly dependent on your IGF. So you need to be very strategic to open up the scope and make sure that you get the services that are going to ensure additional revenue to your financing, apart from what National Health Insurance Scheme will give you. The next thing as a hospital is begin to look at the kind of competition and the competitive environment you are going to be operating in. Clearly, you must be looking at yourself as a monopoly now. But the truth is that as you go forward, I heard your acting CEO talking about the OPD statistics. And for me, that is how we all began. But in some service areas, some of us are beginning to see figures coming down. And it's all because we are beginning to encounter serious competition from other providers. As you grow to specialize in the provision of services, you are going to be losing some of the general care areas. And that means, the loss of revenue. And that's the reason why for us, we must begin to strategize and tap into areas where people will find very difficult to compete with us. Home may look a small city, but I'm telling you very soon, you will find private hospitals, other hospitals springing up to compete with you. That's the challenge for Kolebu and Konfarachi currently. So you need to be very strategic as you move forward. I must say that the statistics that have been posted by the CEO in his speech are very similar to the one that we are having. And I think the Honorable Member of Parliament spoke about some of the statistics. I'm sure he has gathered a lot of readings in terms of what figures they are reading in Parliament. And I'm happy that they know the trend, because it is something which is very critical, and we must do something about it. Because if we look at us, in saving lives under the universal health coverage team that we are all canvassing for now, we must begin to specialize very deeply. If we come to Kumasi now, we have begun to expand into various areas. If we come to, let's say, care for cancer patients, Kumasi is currently reigning #1 in West Africa, because we have installed a LINAC machine, which is the state of the art and the newest in the whole of West Africa and south of Sahara. This is giving us opportunity to be able to care for even newborns with cancers. Previously, we didn't have such an equipment that can really tailor radiation to specificity when you want to target a particular cancer cell. We have begun to do a new technology of surgery, where when you want to close the hole in heart, which is a common term that we all know, you don't need to open the chest. You don't need to open the heart anymore. With a little catheter and a material, you can pass it through a vessel in the thigh, straight away to the heart to go and close that hole in the heart, all in 45 minutes, and the patient go home in 2 days. We are doing joint replacements of all types: knee, hip, elbow. And these were surgeries where previously it was very, very challenging. And people had to go outside to spend hard currency to have them done. Today, if your hand is completely severed off, it can be re-implanted so that you can have your hand functional and the way naturally you were born. So these are some of the innovations that we are all doing. And I think that it is very, very important that as a teaching hospital, as you begin to look at the horizon, as young even as you are, we must begin to tap into these areas. Because I think if you look at our demographics, clearly, and I'm sure the Honorable Member of Parliament will share in this, we need these things replicated in every region. Because as he indicated, as a former General Secretary of the Ghana Medical Association, I have not been very comfortable at all when you look at the personnel distribution in the country. As a GMA Secretary looking at about 2,000 doctors those days, you know, we had districts in Ghana that had only one doctors. District in Ghana that had no doctors. And the that's what we call the one-man stations. Currently, I'm told from the Ghana Medical Association data that doctors in Ghana are numbering between 7,000 to 8,000. But even as you speak, we still have districts in Ghana, no doctors. We still have districts in Ghana, only one doctor. So how did we improve? Where did all the additional doctors of 5,000 go? And that's exactly the kind of thing that the Member of Parliament spoke about. As a country, we must be strategic to stem the tide. Otherwise, our health indicators will never improve if we keep to the status quo, where everybody who wants postgraduate training, anybody who wants a good lifestyle, is want to stay in Accra and Kumasi. And that's why we are happy to support the whole teaching hospital. As I speak, I know that we have provided at least between the hospital and the university, not less than about 12 top-level staff to assist your HR development. Obstetrician gynecologist, a lab specialist, your director of administration, director of HR, and many others. And we think that whole needs to be supported to come very, very close to us. Just as we think all other regional hospitals must also be able to develop. I think with your rich stewardship, we hope that the statistics that we are all going to learn from here, it will guide all of us. And I must say that we are not here to just share our experiences and our good outcomes. As young as we are, I think we are also going to learn from you. Because certainly there are good things for the young ones that we can learn from. Thank you very much for your audience.
Thank you very much. Please put your hands together for him. Shall we welcome the acting CEO of Tamale Teaching Hospital, Dr. Karim Mumuni.
Thank you. Mr. Chairman Togwe, permit me to stand on existing protocols and existing on the shoulders of the giants previously mentioned. I bring you greetings from the north, specifically Tamale and Tamale Teaching Hospital. As being the last CEO to talk, I have the advantage of summarizing what colleagues have said or criticizing them. Yes. To talk of the whether old or new, it's also interesting that I'm the newest CEO, acting CEO, less than 3 months old. And that also gives me the permission to be able to speak as a child, and so I can say things as they are and as I want to say. I must say that the theme for this performance review couldn't have been more appropriate than it is. That says, setting the agenda for innovation, innovative tertiary healthcare, caring for everyone and learning from everybody. We need real innovation. Without doubt, everybody knows that. With the changing circumstances in health delivery, All we need is innovation. How do we go about it? We should appreciate that healthcare is expensive. It costs money. But we are faced with having to to provide this care cost effectively and then making it accessible. So we have to balance cost and access to the care. We're a tertiary institution. People would come, and because it's expensive, may not be able to afford it. And that's where the innovation comes in. We need innovation actually in everything we do, so to speak. And for me, we even need, especially, innovative prayers if God has to listen to us. We've done things in the past the same way for too long. Most of these challenges have been mentioned, and most of what you've heard has been mentioned for too long. We need real innovation. And I'm happy we have representation from Parliament, and I salute him with all that he delivered. But I must say that as we tend to innovate, to care, to fund, and so must central government innovate to provide funds. The innovation shouldn't be on only our side. I told you that I'm the last so I can speak, and I'm a child so I can speak. Because we've often had no funds from central government for too long as well. And so they need to put their act together, innovate, to make funds available as well, to meet us somehow. Most of you would know what I'm talking about, especially if you've heard stories from the teaching hospital that I am in now. And we must face it. Everybody needs some form of innovation in everywhere we work, if we have to address and move forward. There's no doubt about that. And so I challenge everybody, wherever we are, to take that up, that we need real innovation. I must say that the challenges that Ho is facing is not any different from what we are facing. And so, for me, exactly taking this team, we are going to be collaborating with with Ho in particular. This is just you keep hearing me mention Cape Coast because Cape Coast was the first one I attended. This is the second one. So sometimes I tend to. And when I was called to take up this position, my mentors are here. And then Dr. Tampri, we've known each other since my house job. And so he called me to give me direction. And I'm so grateful and happy that they did that. And so we're already collaborating. I must say that being the newest, it was mentioned that they have all the attention. Being the oldest, he had all the attention before, because he was the eldest. That's Kolebu. The other three have been in the middle. So it's time we have some form of innovation to also get attention. So we're going to be innovating, and that's what I'm learning from here right away, so that I can also have some information, some sort of attention. And so on this, I would say that we are here and we have started the learning process already, knowing that you have to do things differently to be able to deliver healthcare. Having said that, we've talked about healthcare delivery. We should look at it holistically as well. We've talked of most of the doctors being in maybe Accra and Kumasi for training purposes mainly. Yes, of course. But we should also look, I did mention this in Cape Coast, we should also have to look at development holistically. You are not sending that single doctor to a district where there's no good school for his family. Otherwise, he shuttles between the two places where there's a good school and where he is. His attention is not often so much in the work. And so we have to start to look at development, and that's why WHO says that we should begin to put health in all policies. And I want Honorable to take it back to Parliament and let them put health in all policies, whether trade, education, foreign affairs, anything. They must put health as part of their policies. They must address health issues. Because that's the reality. The single doctor working in a single place has the risk of when he gets his cardiac arrest, nobody else is going to be there to help him. Because he's alone. Nobody knows. So we must look at things holistically as we move forward. Let every single district also have a good school. Then would have more doctors because they know that they are not sacrificing their families when they go there. We have to look at it holistically. And so, Mr. Chairman, on this note, I would say we are here to learn and also to support which we are just twins, so to speak. Thank you very much.
Another round of applause for all the CEOs of the various teaching hospitals we have in the country. Oh, please put your hands together for the CEOs of the various teaching hospitals we have in the country. We want to take one last thing before our snack break. We'll take an address by the special guest of honor representing the Minister of Health. Please put your hands together as we welcome Brother Lawrence Lawson, the Deputy Director at the Ministry of Health. Please put your hands together for him.
Thank you, MC. Right. Dogby Chair. Our honorable member from the House of Parliament, acting CEO of the whole teaching hospital and staff here present, CEOs of the various teaching hospitals here, ministers of the gospel and Islamic clerics present, Togbeo, Mamao, officials of the Ministry of Health here present, officers of the security services here present, development partners here, invited guests, distinguished ladies and gentlemen. I present this on behalf of the Honorable Minister who is also engaged in another equally important activity. Actually, he planned to be here, but as was mentioned, as was stated to you, he's engaged in another equally important function. And I bring warm greetings to you all from the Ministry of Health. And I'm privileged to be with you today at this year's performance review program. I therefore wish to commend the management and staff of the hospital for a very wonderful work during the year under review. Whether 10 months or 1 year is under review. It is my ministry's intention to make this teaching hospital a model teaching hospital, hence the first to pilot the new governance and management arrangement being proposed as far as the management of the teaching hospitals are concerned. Talk Chair. I know the hospital has been assessed by all the health professional regulatory bodies for the purpose of accreditation and recommending appropriate human resources and equipment required for quality service delivery as a teaching hospital. Their recommendations have been taken into consideration and the ministry is doing everything possible to address them and promise that we will give you the necessary support. The ministry is also aware of the infrastructure gaps and the need to fill that. The ministry is working towards acquiring funds to expand the infrastructure for service delivery, including additional wards, offices, and many others. Also, the ministry is working at getting funding to retool the hospital and acquire new equipment to enhance service delivery, such as the CT scan, medical laboratory equipment, anesthesia machines, and many others, in a way to also get the MRI machine back to operate. Ladies and gentlemen, I'm reliably informed that sometimes patients referred from the region to Kolebu find it difficult to go because their relatives may not have a place to stay in Accra to attend to them whilst on admission. I believe if we are able to resource this hospital well those patients could be treated here and may not need to go to Kolebu Teaching Hospital for treatment. Critical to provision of tertiary health service is the issue of human resource. And I'm happy to inform you that in 2019 alone, 274 newly recruited health personnel were posted to this facility to beef up the human resource capacity. This included medical officers, nurses, administrators, medical laboratory scientists, and many others. In addition, 3 senior management members were reassigned to the hospital to assist improve the governing structure, and the feedback I am getting is refreshing. Togbe Chair, ladies and gentlemen, I am convinced from the reports received so far that staff are working hard to ensure that the hospital achieve its mission and vision. We at the Ministry of Health will also do everything possible within our power to get the hospital a befitting status in terms of infrastructure, equipment, technology, human resources to enable you achieve for yourself the theme as indicated here, setting the agenda for innovative tertiary healthcare, caring for everyone, learning from everyone. Personally, I have taken official notice as the CEO enumerated the challenges of the facility. And I promise that I'll take same to my superior officers so that the necessary stakeholders are engaged towards addressing the enumerated challenges. Togbe Chair, I wish on the basis of the aforementioned to urge management and staff of this hospital to continue to work even harder in the coming years to make this hospital a preferred choice for medical care. Thank you, and may the Lord Almighty, the most gracious Jah, the Allah, the ever merciful, bless us all. Thank you. Absolutely.
Thank you very much. Please put your hands together for him once again. At this point, I know we are all tired. Someone to take a drink, someone to stretch their legs. Before we go out, I want to make this quick announcement. If you want to visit the Nature's Core, just right when you come out, just before the staircase, the washroom is on your right. You can access the washroom from that point. We'll be going down to where the restaurant is, in front of the restaurant for our snack break. We'll let those on the high tables move out first, and then we can subsequently join them. The chiefs will also go in, then we can subsequently join them for our snack. Yes, the snack is only 30. We have 30 minutes for snack, so please let's quickly do that and then come back and take care of the part 2 of today's program. Thank you very much. Please let's rise as we go in for our snacks. Try two. Try two. Try. Try. Try two. Try two. Check 1 2. Check 1 2. Try two. Try two. Check. Try.
Yeah, that's what I'm trying to set up.
Try two. Check. Try two. Check 1 2. Try. Try two. Try two. 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 Try two. Two. Two.
Yes, mine's now. I'm hungry. Ah, so what was there?
Hello. 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 Hello.
Two. Two. Try two. I'm trying to set this one up. Two. 1 2.
Hello. Testing mic 1 2. Testing mic 1 2. Hello. Hello.
Hello, 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 hello. 1, 2. Try 2, 2.
Hello? Yeah. This mic is for questions. Hello? Okay.
Please, car with registration number GR 286415. Please, you are not properly parked, so you are advised to please move your car from where it is. GR 286415. Thank you. Thank you. Shall we put our hands together for the choir? Shall we put our hands together for the choir? Oh, come on, appreciate the effort that the choir is putting on. Thank you. Please give them a round of applause. You are welcome back from our commercial break. We are going to take the second part of today's program, that is the presentations of the performances for the past year, 2019. So without wasting much time, please put your hands together as we invite Mr. Jokoto to give us the presentations.
Thank you, MC. Togweche, CEOs and directors from the Ministry of Health, all invited guests, all protocols observed. I stand on behalf of the Acting Chief Executive to do this presentation on the performance of the hospital since the place was inaugurated as a teaching hospital. But we'll go beyond that in retrospective so that you understand exactly what has been happening, and after the inauguration, what we have done. Our presentation outline looks like this. We'll look at the background information of the hospital, a brief one. Then we'll look at how we align our strategic objective to the health sector objective. Then we also look at the priorities of the hospital for 2019. What were the achievements by the hospital, looking at it vis-a-vis the sector objectives. We'll look at some of the challenges that we encountered in 2019, and then what is our outlook for 2020. As a brief background, the hospital was built by the Kavena Construction International of UK and commissioned as the Volta Regional Hospital in April 1999. It was commissioned by the First Lady that time, that's Nana Ajima Rawlings, and in 2000. It went through processes until April 2019. Specifically on the 29th of April, we were recommissioned as a teaching hospital. Currently, it is a 300 bed capacity hospital. This is where we are now. So if you come to the hospital, this is the main entrance, and the administration block is here. And you can see all the other facilities that we have in the hospital. And just at the side, we have the University of Allied Health and Sciences. University of Health and Allied Sciences, part of their campuses are also on our premises. What's the mandate of the hospital? By the Act 525, we were mandated to provide advanced clinical services. We are supposed to do medical education, both the pre-service and then the postgraduate training. We are also supposed to do research and also support the primary and secondary level facilities. Our vision as a hospital is to be the premium in innovative tertiary healthcare, medical education and research. And our mission is, as a whole teaching hospital, in collaboration with the relevant stakeholders, we exist to provide quality health services, medical education and research by committed staff and dedicated staff exceeding the expectations of clients. Our core values are commitment, accountability, dedication, integrity, professionalism, innovation, teamwork, safe care. In short, it is a cadipit. So we want to look at the health sector objective vis-a-vis our strategic objectives. The health sector has 4 main strategic objectives. The first one is to ensure affordable, equitable, easily accessible, and universal health coverage. And we try to align our strategic objective of expanding infrastructure for service delivery, training offices, and residential accommodation, and also collaborating for innovative tertiary health services and specialist outreach services. So we try to align these objectives to the health sector objective. The second health sector objective is to strengthen healthcare management system. And we also plan that we want to improve good corporate governance and management practices. Again, the third objective of the health sector is to reduce disability, morbidity, and mortality. And as a hospital, we thought that when we do continuous improvement of quality of service, we should be able to reduce disability, morbidity, and mortality. We also think that whilst we improve teaching excellence and learning experience, that is also going to help to reduce disability, morbidity, and mortality within the country. The last one, which is ensure reduction of new HIV, AIDS, and other infections, we still going to align our continuous improvement of care and then collaboration in order to achieve these health sector objectives. What were the priorities for 2019? We plan in 2019 to expand existing infrastructure. We also plan to introduce additional specialist services because our status has changed. So the existing specialist services that we were having were not adequate in order to meet the demands. And then the new status that we have. So we try to introduce additional specialist services. We all know, and it's all over, that the then Volta Regional Hospital, and when we transit into a teaching hospital, is applauded always as the most cleanest hospital in the country. And so we still want to make sure that we improve upon our environmental and sanitation conditions within the hospital and make the environment serene for healthcare delivery. We also want to strengthen hospital management and administrative practices, attract additional human resource, acquire accreditation for training of residents in general surgery and psychological medicine. We also want to acquire accreditation for tertiary services from HEFRA and credentialing for tertiary tariff from National Health Insurance Authority. So, in all these priorities, how did we contribute to health sector objectives? Under the health sector objective 1, we collaborated very well with UHAS to complete and furnish additional 6 consulting rooms, which we are currently using for our specialist consultations. We also collaborated with Rotary Club to release a limb fitting center that was constructed since 2009 and has not been in use. So we thought that it is a very good thing that we can use that facility, convert it into a polyclinic so that we can separate the primary health services from the tertiary health services, so that patients that are coming to the main Trafalgar or whole teaching hospital are seen as specialist services, and all the primary health services will go to the polyclinic. Thank you. So this place was released to us by the Rotary Club last year. So we are working towards renovating it in order to use by the middle of this year. Again, we tried to drill 2 additional boreholes to have up to about 6 boreholes in the hospital. And we didn't leave it there alone. We tried to install reverse osmotic equipment in collaboration with Life for Relief and Development to address the erratic water supply in the hospital. So this is one of the additional boreholes that we try to construct. And this is the reverse osmotic equipment that we installed, and it is housed in this building. We are trying to distribute the water to the various areas within the hospital. This platform is meant for redistributing the water to theater. This is where I was talking about. That's the limb fitting center that was abandoned. And in fact, if you go there now, even the electrical installations and things has been removed from that place. So we need money to be able to renovate this place, do some little expansion, and then make it useful, because it has been there for almost 10 years. So we can't leave it there to like that. So we are thinking seriously to improve the whole area and then make use of it. The consulting rooms that I talked about, these are 3 consulting rooms that the UHAS was able to do for us, and we try as much as possible to furnish. And so the picture here is depicting some of the things that we put inside. In terms of the infrastructure, again, we try to put up a cardiothoracic center. If you look at this structure, you think that it's part of the old structure that was built, but it's a new thing that we have added to the main building, and did it purposely that you don't even see the difference between the building. Again, we added some specialist services. I talked about the primary healthcare wing. Whilst we are waiting to renovate that place, we try to introduce the primary healthcare at the OPD. We are going to relocate them to their permanent site. The cardiothoracic center is now working. Pain management is also working seriously now. Emergency medicine is also working very well. Audiology and speech therapy was also introduced. Gastroenterology, nephrology, and urogynecology were also added. We also tried to put up a pharmacy and nurse to help us bridge the gap between for pharmacy services. We tried also to organize outreach services to the communities and some facilities. So what are the key performance indicators to show how we have all the investment that we have done is shielding? This is a trend of OPD visits to the hospital. You can see a steady increase from 2016 to 2019. Between 2018 and 2019, the percentage increase, though it's small, we know it's going to pick up because immediately after the recommissioning, we realized that some patients have also started running away from us because they thought it's now like callable, so when they go there, we might not give them necessary treatment as they expect. So some started going away. But along the line, they realized that they can't do without us, so they had to come back. You also see an interesting trend here. The gap between the total OPD attendance and then health insurance, the insured clients, from 2016 to somewhere around 2018, the gap has started increasing, meaning that there are more patients that are coming with the, how do you call it, out of pocket, or no, the non-insured clients are now increasing. And the percentage change in the insured clients, even though it has also increased by 7.9%, but the gap between the non-insured and then the insured is also widening a little. We also want to look at the productivity of our doctors. If you look at this, you realize that during the holistic assessment, when we are setting the target, we set a target at 1,200 per doctor, 1,200 patients per doctor. But if you look at this, you can see that our doctors are being overworked. And probably also the quality of the service that they are receiving. There are two sides of this coin. We are making maximum use of the doctors, but that in a way might also be affecting quality of care. Therefore, if we have set a target at 1,200 and they are doing this number, it means we need additional staff, medical officers, in order to bring down the number of can perform better than we are doing. This graph is showing the trend of admissions within the period. That's from 2015 to 2019. Here, there is also a marginally increment in the number of patients that we admitted from 9,323 to 9,522. And that's about 2.56%. And if you look at it, again, from here, the insured clients that were coming to the hospital as compared to, from this area as compared to this side, you realize that the gap is closing. That's also telling us some story that the non-insured are really not patronizing the services at admission. We talked about the productivity of the doctors. That of the pharmacists is worse. If you look at there are three graphs here. If you look at this shows the number of prescriptions per pharmacies, the number of prescriptions that they serve. And you can see it's increasing. As we speak, we have only 8 pharmacists in the hospital. And so there is pressure on them. That's also going to affect the quality of care. So if we are not able to send more pharmacists to the hospital, it's going to have a lot of this thing on the hospital. So we are appealing to Ministry of Health to help us at least get the pharmacists. We understand that it's very difficult to get, but take us as a priority, because if you want us to move forward, we are poised to do everything. But if we are not getting the adequate number of staff, it will be very difficult for us. Diagnostic services. This one too, almost all of them are increasing. Though in 2019, the number of ultrasound has fallen. Management is putting everything in place to make sure that we go up. The fall was due to, one, we don't have adequate equipment, that's the ultrasound machine. So sometimes the pregnant women come and queue a lot. And because the services are not readily available because of the equipment that we have, some of them have to leave us and go and do it somewhere else. So we need the equipment in order to do a lot of those cases. If you look at blood usage and then blood donation, there is another interesting story here. You can see the usage here, or the bloods that we have issued in 2017 and 2018 were more than what was donated. But thank God in 2019 there is an improvement. Now the reason behind why there was more issue was that when we don't have blood and people are referring, sometimes we try to call on them to get blood in addition whilst they are bringing the patient. And when they come, we try to rescreen the blood before we use. So that accounted for the difference in the issued and then the donations. Surgical operations. It's on the increase in both areas. But significantly, we need to talk about orthopedics and ophthalmology. They have done a lot of work. And then Operation Smile and Operation Hernia were also part of this trend. Now, if you look at the surgeon-surgery ratio, one surgeon is doing 73 cases in the year. So, in terms of health sector objective 1, this is how we fared. We'll now look at the health sector objective 2, which talked about strengthening the health care management system. Under this, as a hospital, we try to review our earlier strategic plan that we developed, that is 2016 to 2020. Because the status has changed, we need to realign some of the objectives that we had earlier and then repackage it. So we now have a strategic plan which is running from 2020 to 2024. Again, we try to start our concept of sub-EMC. We have identified some key personnel. We try to interview them to know their vision towards the various sub-EMCs. Basically, we are creating about 4 of these clinical sub-EMCs as a start. We are yet to do a team building for them so that they understand themselves properly as they are managing the sub-EMC, so that they don't just go there and then whilst the lead clinician is going this way, the head of department is going that way, and the next manager is also going the other way. We want coherence in the department. So we want to do a dynamic team building for them. Give them some leadership training before they start work this year. We also agreed that we are going to sign a performance agreement with them just after we do the training. So that will be done this year. Again, in the 2019, some key personnel were posted, as you heard from the Chief Executive's welcome address. Key are the administration and support services, human resource management, and research policy planning, monitoring and evaluation. We also try to develop some administrative manuals and standard operating procedures to help in strengthening the administrative management processes. We also roll out gift mix after we were inaugurated, and this was done fully in December 2019. We also did a performance audit, and it was based on the performance pyramid. And this was done to align the organizational vision to our internal efficiency and external effectiveness. We also developed some HR guidelines in order to reposition ourselves for attracting additional staff. We were running regional hospital organogram, but when we change to a teaching hospital, we have to realign ourselves properly. So we try to redesign the organizational structure of the hospital. Some key additional departments were also created, such as the PRO. Hitherto, there was no research, planning, monitoring, and evaluation office. The human resource tool was operating under the Office of Health Services Administration, but it was also realigned, and then we want to have one directorate to manage the human resource. We also did some training for the ward in charges and their deputies so that they can manage the beds very well in the wards. So bed statistics was taught them, and they now understand the utilization indicators well. When it is increasing, what they need to do. When the average length of stay is increasing, what are the reasons, so that they can take quick decisions on some of these issues. We tried also to engage the heads of nurses training institutions on a holistic management of the trainees that we receive. What are some of the performance indicators relating to strengthening health system management? In terms of human resource, the data here is not very pleasant, but we thank the ministry for at least helping us to increase the number of nurses. But on the other side of it, now that we have moved into a teaching hospital, we have a lot of the community health nurses and enrolled nurses. There's a need for us to attract a lot of the professional nurses so that we can attend to our mandate appropriately. Pharmacy, the figure you are seeing here includes medicine counter assistants and others. I mentioned earlier that we have only 8 pharmacists. Administration, that's the number. Human resource, there are 8. If you come to PPME, it's a single person office now. Now look at the doctor situation, and even this number that you are seeing here includes the UHA staff. We have only 1 radiologist, and you can see that is also having effect on our ultrasound and the other imaging diagnosis areas. There are 2 radiographers. The professional nurses, as I mentioned, they are about 256. And you can see the number of the enrolled and community health nurses, 148. And it's still increasing. Midwives, they are now 83. Pharmacists, I mentioned that. And there is only 1 pharmacy technician. In order to address some of the challenges, we try to vigorously, in 2019, increase the number of study leaves that we have granted to the staff. Hitherto, at this time, study leaves were being granted by the Ghana Health Service, but from 2019 going, we started on our own trying to vigorously pursue our agenda of beefing up the human resource situation of the hospital and also to expand our specialist services. These are some of the areas that people are having training in there as part of the training and development. Financial resources. This is a trend of our performance in terms of finance. The chunk of the money we receive is coming from the National Health Insurance. And this is what we are having from the non-insured. Both sides are increasing. And we hope that if we are able to introduce additional specialist services, we'll be able to get more money from there, because since the reimbursement is also a problem, we need to look for other areas, specialist areas that we can invest a lot of money into in order to generate more revenue to run the hospital. Again, these are the sources of revenue. In 2018 compared to 2019, you can see that the revenue from medicine has declined, but services is increasing. Now, there is a reason for why this one has declined, because of the prices of medicine from the National Health Insurance. They have reduced price somewhere along this 2019, and that has also affected the revenue we generated from medicine side. But if you look at it generally, there is a steady increase in revenue mobilization by the hospital. In terms of expenditure, the major expenditure component is from the goods and services, followed by the compensation. And so if we are paying this amount, and as a baby hospital, teaching hospital, we are still pleading that the ministry should help us to get additional staff so that we can reduce this amount and then invest that money rather into capital expenditure so as to get additional equipment and then provide logistic for service delivery. This shows the gap between the revenue and then the expenditure. In 2018, there was some decline in the expenditure pattern. But because we have moved to a tertiary facility in 2019, you can see that we have started picking up again in terms of the expenditure, because we need to invest a lot into equipment and other things. If we look at this table, it is telling us that the payment from or claims reimbursement is not very good. The percentage of submitted claims paid by National Health Insurance, you can see in 2019 it was only 21% that was paid. So the rest 79%, we are still waiting for it. And we don't want to wait. We need to do a lot of things. So we are pleading. I hope they are here. So they will take it up and then help us get money in order to run the hospital. Now, if you look at it, this is also having an effect on the debtors' days. Because if they are not paying us, you can see that it takes about 274 days to settle our debts. Now, so you see that creditors' days is 147, but you can see we are doing well. If it's taking us about 274 days, and we are doing less than the 200, because we need to get the money from them before we can also do something. But that's also affecting us. We have to squeeze ourselves in order to pay those who are supplying us. And if we don't pay them too, it means that we can't get resources to work with. So we have to plead with National Health Insurance to do very well and then give reimburse us as early as possible. In terms of transport situation of the hospital, this is not a very good data to present. There are three main pickups that we can say we are using. And this is what the chief executive is using. And you can see this one, the way it's running. This one to the way it's running. As for these two vehicles, they are not vehicles that we should talk about. If they bring some of them here, you will run away. You think that it's a plane that is coming. So if you look at the age of the vehicles that we have, at least these ones, they are almost grounded. And those two vehicles that you saw are all here. And the three is what we have here. And these three too, they are ready to stop. So it means that probably by next year, we might not have any vehicle available. Please, ministry, we are begging you, help us. In the midst of all these challenges, in terms of resources, we are trying hard to what? Reduce disability, morbidity, and mortality. How did we fare here? We tried to introduce new we received some new specialists in the areas of general surgery, orthopedics, pediatrics, gastroenterologists, and then urology. And then we tried to introduce new specialist services, as I mentioned earlier. Those of us in town, this realization clinic is something that we must all try to patronize. It's yielding a lot of results. So let's use that place very well. We believe that you will enjoy their services when you go there. We also sponsored some medical officers to pursue their membership programs. So we sponsored 4 people in the area of medicine, both in country and out country. 2 from surgery is also currently in school. There's 1 in pediatrics, OBGY, 1 person is there, and then radiology, there is 1 person there. So we are doing everything possible to make sure that we build up the various specialist areas, and then so that we can provide services appropriately. We tried to operationalize the obstetrics theater, which was not operational for a long time. We also added additional equipment like the patient monitors, diathermy machine, patient roller, new incubators for the NICU, phototherapy equipment, ventilators, and a dental chair. We also received some assorted physiotherapy equipment with the support from PhysioNet, Kekeli Foundation, and the Rotary Club of Ho. One key area that we will say we are really forcing ourselves to make sure we reduce disability and morbidity is we have a very functional medicine and therapeutic committee. And because of the work they are doing, we have agreed that we will not transport any heat-sensitive medicine to be taken by anybody at all. If it is not in a cold chain, it will never leave the pharmacy. So if you look at our bed utilization, I want to compare emergency and then the hospital's performance so that you can see the type of pressure on the accident and emergency. And we are appealing that everybody who can help should help us to at least expand the accident and emergency, because the situation is not very pleasant there. If we don't do anything now, that's going to affect the services that they render there. Now that new ambulances have come, it means that a lot of them will be trooping in there. So we need to expand the place, because hitherto, because the ambulances were not available, it is difficult sometimes even for them to rush and bring the clients. But now that we have a lot of ambulances, every now and then you hear their siren coming. So we need to improve that particular place very well. So you can see that the bed occupancy rate for the hospital in 2019 is around 67.7, but that of the accident and emergency is 88.7. And worldwide, if you see your bed occupancy rate going beyond 85%, no, there's danger, because that's also going to affect the quality of service that you provide in that area. And you can see that one bed you have at the accident and emergency is servicing about 130 patients. So the average length of stay for somebody, or the turnover interval, the period within which somebody will vacate the bed for somebody to occupy it again, is also very small. And that is also not good for quality of service, because you have to take good care of the beds before they reuse it again. And this is the average length of stay situation at the hospital, and that of the accident and emergency. Now, if you look at the accident and emergency, because now there is a resident emergency medicine physician there, he's trying to control the situation at that point. If you look at the death patterns at the accident and emergency, the red one here, that's about 43% of the people that came to the accident and emergency died less than 24 hours. And it's only the 57% that survive beyond the 24 hours. So if we don't increase the number of people in the accident and emergency, there will still be pressure. And this one is also telling us that if you are somebody between 31 to 80 years, the probability of you dying at the accident and emergency is higher. What are the top 10 causes of admission in the hospital? Severe malaria, cardiac failure of the cardiac congestion, anemia, CVA are all contributing majorly into the causes of admission. The top 10 causes of OPD attendance: uncomplicated malaria suspected is also high. Upper respiratory tract infection, hypertension, and then pregnancy related contributes about 9%. In terms of causes of death, the CVAs and the CCF are the major causes of death. The prematurity is also very high there. Now, if you look at the maternal mortality, the institutional maternal mortality, this one, our member of parliament was talking about it this morning. You can see it is on the increase. Yes, Dr. Asari also mentioned it, that we shouldn't be so much worried because it needs to happen. But we also need to put measures in place to reduce this maternal mortality. And in the speech of the chief executive, he mentioned that out of the deaths that occurred, 19 of them, there were 20 maternal deaths. 19 of them were referred. Now you also understand the road nature in the region. So that also affected the way they come into the facility. Now, out of those that were referred, the 19 that were referred to the hospital, 4 of them died less than 24 hours. And these are the major causes of maternal mortality. Hypertensive disorders contributed a lot. Sepsis, hemorrhagic shock, pulmonary embolism, and sickle cell crisis were the major causes of the maternal death we received. This graph is telling us about rising cesarean section rate, rising low birth weight rate. We are thinking of conducting a research to find out whether there is any correlation between the low birth weight rate and then the cesarean section rate. Because normally, usually, it's like whilst you want to save the baby, you must quickly also go into cesarean section. Then the stillbirth rate is also reducing, but started picking up again in 2019. The institutional maternal mortality rate is behaving funnily here. It goes up, comes down, and goes up. I think the blue one indicates neonatal mortality rate, and the red one is about the infant mortality rate. And so you can see the contribution of the neonatal maternal mortality to even the infant mortality rate. At the NICU, or at the pediatric department, I think this one is mainly about the NICU. The cases that are being referred to the NICU, we had referred ins as this, but these are the referred out. What it means here is that our referred outs are mainly surgical cases because we don't have any subspecialty in the pediatric surgery. Then the congenital malformation also is another area that is causing us to refer out to other facilities like Kolebu. We are still pleading that we need to beef up the human resource at the pediatric unit so that we can have some additional subspecialties to run the place. Theater mortality in 2018, exactly, we don't know. There were 2 theater deaths, but thank God in 2019 nothing happened. Medicine and therapeutic committee activities. I mentioned that they are very vibrant, so you can see the type of activities that they were carrying out. They did RUM, they were able to distribute STGs and then the essential medicine list to every clinical department. They disseminate most of their adverse drug, they update staff on the adverse drug reaction. They also conducted training on antimicrobial stewardship, and then they updated staff on the antimicrobial stewardship program. If you look at the RUM indicators, average number of medicines prescribed per encounter has gone down to about 2.96, which is close to the national target. Hitherto in 2016 and 2017, we were doing beyond the national target. Then the percentage of medicines prescribed by generic, because we are using the a software to manage all our clients, you can see everybody prescribes by the generic name. The percentage of medicines prescribed from the essential medicine list too is the same. That of the antibiotics prescription, the national target is 30. But you can see that we were doing far beyond that from 2016 to 2018. And we have reduced it drastically to 32.2 And similarly, if you look at injections, it also follows a similar pattern. This is because of the work the Medicine and Therapeutic Committee is doing. They try to disseminate information at heads of departments meeting, clinical meetings, etc., and that has helped to reduce those indicators very well. What about pharmaceutical care interventions that they conducted? Major interventions were in the area of subtherapeutic doses, improper medicine selection, inappropriate frequency of administration. In all, there were about 78 interventions. Change of treatment or medicine is also a bit high. Counseling needs, and then duplication of therapy. So these are some of the interventions that the medicine and therapeutic committee did in order to help reduce disability, morbidity, and mortality. Our tracer drug or tracer medicine availability in 2018 has come down, but it has started picking up a little. And this was based on, is it 50? The issue here is about the regional medical stores not able to stock most of the medicines, and we have to go to open market. We have just started. So in terms of research, these are some of the things that we have done. We try to develop a research policy and also develop our SOP for ethical review committee. The committee itself is here to be constituted so that we can do our ethical reviews within the hospital. In 2019, from the middle of the year, because we were not documenting well the number of student researchers that came with ethical approval from the school, we have started documenting them. So we're able to record about 6 students who are conducting research. We also collaborated with the Ministry of Health, the Fleming Fund, and the University of Ghana to implement the surveillance activities of Ghana's National Action Plan on Antimicrobial Resistance Program. And it was during one of these programs that we lost one of our staff in an accident. May his soul rest in peace. These 2 public researches were also published, and if you Google the topic, you'll be able to find it. The pharmacy department also did a rational use of medicine indicator study, and there were client satisfaction survey conducted in some departments. It was not done to cover the entire hospital. So in terms of reducing disability, morbidity, and mortality, that is what we were able to do. We are now moving to the 4th indicator, and here we were able to test about 1,866 clients, and all of them were cancelled after the test. The number positive is fluctuating a little, and all of them were put on the ARVs. The early infants diagnosis. In 2019, the total number of HIV exposed infants identified at the hospital were 39. We were able to screen for HIV using the PCR form for age 0 to 6 weeks. For age 0 to 6 weeks, only 24 of them. And the number that was positive was 1. Number tested, that's 6 weeks, more than 6 weeks to 18 months, were 10. No positive, number positive after 18 months was 0. Post-exposure prophylaxis. These are needle stick injuries. You can see the figure is increasing in 2019. This was mainly due to new staff that we have received who do not really understand some of the procedure, the SOPs and the things that we have put in place. Those we received from other facilities also increased to about 15. We saw some rape survivors, about 6 of them. New drug resistance activities. The number of people we put on treatment were 19 in the year under review. And number of them that are dying before the initiation of the treatment were 2 in 2019. What are some of our major challenges? Delay in reimbursement by the National Health Insurance. I don't want to talk about it more. Accommodation is a key challenge. Currently, you come to the hospital, it's difficult. Every small space, you need to find somebody to work there. So it's putting a lot of stress on management. Especially at the administration area is one key area we need to look at. Offices are not available. Key again is the residential accommodation, and to this end we are pleading with our traditional authorities to help us a lot in this regards, because if we want the teaching hospital to stay, then we need accommodation for the doctors when they post them and they come. Sometimes even, I think Chief Executive talked about the amount of money we are putting into renting accommodation. Oh, don't worry, I haven't finished. Don't worry, I haven't finished. Even myself, there's no accommodation for me. And where the chief executive himself is even staying, it's not something that we should. So if we are talking about the higher people, what about the lower people? If it's difficult for us to get accommodation for doctors, then what about the other staff? So we are pleading, even the rent, sometimes you go, is too high. Staff cannot pay for some of these rent. So we are appealing with the traditional authorities to help us in this regard so that we can get accommodation. Because the accommodation, if we don't get it, then we can't attract the people to come and work here. You can see, as we indicated here, inadequate human resource. Hello? We are talking about inadequate human resource. And I mentioned the accommodation. If we don't get the accommodation, it's difficult for us to get these people to come and work. One other area too is the inadequate health technology. Because we want to be innovative, we need a lot of high-class technology in order to do minimal invasive procedures. Transport, I don't need to talk about it. You have seen the picture yourself. So what is our outlook for 2020? The health sector objective is not ending now, so we are still moving with the health sector objective. We are still pursuing our expansion projects. We are still trying to attract specialists to the hospital. I need to talk about the medical officers here because if you have specialists and you don't have the middle level manpower, it is a problem. So we need a lot of the medical officers so that they can assist the specialists to run the hospital. We want to continue with organizing quarterly outreach services, and we are in touch with Rotary Club International, Rotary Club of Ho, and other philanthropists in order to get some mobile vans in order to do quarterly outreach services and also do mentorship programs for our health facilities. Because you realize when we were presenting on the mortality, the maternal mortality, the problem we are having, and we mentioned that a lot of the referrals are coming from the peripheral. So we need to go to the peripheral and support them. So there's a need for us to work towards using the outreach services and the mentorship programs in order to reach out to these facilities. The limb fitting center, we promise we are going to renovate it and relocate the polyclinic to that place. In terms of the hospital management, strengthening the hospital management system, we will continue and finalize the decentralization process we started. We will continue to formulate and update local policies and SOPs to strengthen the management system. We want to implement a biometric attendance management system. Now that we are going folderless in the entire hospital by next week. We want to finalize the extension of as I mentioned. In terms of quality of service and research mandate, we are trying to implement the caring for everyone, learning from everyone policy by emphasizing on the word cares and learn. And we want to use the learning journal to monitor this implementation of this policy. The learning journal has been designed purposely for staff to document learnings that they are making every day so that we can collate all these things and see how best we can help it to improve the care practice. We want to strengthen research activities by constituting and building capacity for research and innovation committee. We want to introduce new specialist services. We want to implement the research policy, and we want to constitute an ethical review committee to fast track some of the research protocols being developed by the various departments. We also want to institute a research and scientific day for dissemination of our research outcomes. And we hope in the next 2 years, we'll start newsletters that will also publish some of our research activities. We want to reorganize the quality improvement strategy in the hospital. As I mentioned, the current quality manager for the hospital was the one who was involved in the accident. So we are trying to reorganize that area. Then we want to engage appropriate stakeholders to facilitate the quality improvement and acquisition of additional health technology for quality and safer healthcare delivery. Some of the technology we want to acquire. So look at the list very well. If you are interested and you want to donate some to us, our arms are wide open. CT scan, the endoscopy, ultrasound machine, ECG, and then to refurbish the MRI machine. And we also want to exploit and invest into other less invasive procedures. Our plan as a hospital is to move what you saw at the beginning of the presentation to this level. So this is where we want to concentrate our effort. So this is the new additions we want to add to the hospital. The current place is here. So we want to put high rises around this area to increase the number of wards and other service areas. We plan to have a hotel facility with a mini conference center. We we are planning to have 3-bedroom flats. We want to have storage units. We want to have other housing facilities here. We also want to have model housing also here. There are apartments here, 2-bedroom flats, then recreational area. All water that is coming from the hospital will be treated at this point. So this is our developmental plan for the next 10 years. What we are asking is that we are pleading with the traditional authorities. Help us. You have people outside this country. Let them come and support this hospital, and we'll make it big in this region. Thank you very much. We want to acknowledge the Honorable Minister, the Volta Regional Minister, the directors of the Ministry of Health. They are doing a lot of work for us. And we hope that, I hope KK is here. Thank you very much. Put us in the budget, coming here very well. And we invited Director Infrastructure also to be here to see our plan, but unfortunately he is not here. The CEOs, we have enjoyed a lot of collaboration and a lot of tutelage from you. Rotary Club of Ho and International, we are partnering them seriously. They've done a lot of work in the hospital. Our suppliers, we want to say a very big thank you. And we also want to acknowledge all major stakeholders that supported us with cash donation for this program. May God richly bless you. Again, there is this NGO also helping us a lot. That's Life for Relief and Development. They have done a lot of work. Physionet, they've helped us to acquire a lot of physiotherapy equipment last year. May God richly bless you, and I say a big thank you for listening to me.
Thank you very much, Mr. Jokoto, for the presentation. Please put your hands together for him once again. We'll be taking, the CEO will be taking questions and comments from now. These are our data, so questions are only going to be taken from the external people who are here with us. We'll start from the high tables. When we are done, we'll come to the other people in the crowd. Amen.
Thank you very much for the presentation. I wish I were not starting a question, but since I've been given a microphone, I'll hazard some unharmful questions. Like I said, when the whole teaching hospital presented to us their budget, in the budget was some of this presentation. We noticed some of the things I've just seen. And the first question I want to ask is health insurance, payments. So I'll go to finance. You have told us you owe debtors some number of days. And then your creditors some number of days. Health insurance, you're only getting a certain percentage of claims you pay or claims you send to them. Recently, some suppliers like Chamber of Pharmacy have stated that if you are coming for drugs, they can only give you 3 months credit. Apart from that, you must come with what? A payment guarantee. I want to ask, being a teaching hospital, your amounts, claims amounts, are huge. I mean, they are not small figures. They are not like chips compound with 100 CDs or 200 CDs. Yours are in tens of millions of CDs. How many months are you owed by health insurance? 1. 2, I'm not looking for percentage. I want a number of months. Number 2, how much are you owed? And then number 3, with this debt, how are you able to reimburse your suppliers, pay your bills, and pay casual workers? It's very important for us because, you see, we are meeting, and I want this information. We are meeting health insurance next 2 weeks to agree on the formula. And we want to see what priority they are giving to claims payment. And if we know, if I carry, then when I go, I can push that please pay the hospitals. But if we, in the fear, if we anticipate that we'll be attacked, we'll be chastised politically, I cannot do my oversight work. And I always maintain, as for health, disease, it doesn't know political color. Coronavirus has attacked MPs in Iran. It's not discriminating. So I plead, give us the information so that I can know what to tell health insurance. When we coughed a little, I mean the minority, when we started making noise a little, immediately they promised they'll release funds next week. But I know they've not released the funds. So I'm pleading, I would center my questions only on health financing for now. Number 2, I know health insurance is not paying. We are all doing the illegality. I mean, I know it. I was health insurance manager at Home Municipal, so I'm not a stranger to this. Co-payment is happening. And it's no fault of yours. I mean, it's no fault of yours. If payments are coming promptly, you would minimize it to the barest minimum. This morning, I have to send some momo to some 2 patients in the hospital. Somehow they got to know I'm here. And I always wonder how our constituents get to know these things. Because I never informed anybody. Not even my uncle knew I was coming here. And they even said, if I have the money cash, they can just take a taxi and come. So it is real. It's a real thing. So please give us the information on that. With respect to, again, I'm still on health financing. With respect to the insured and non-insured, it's becoming very clear that you are treating more non-insured than insured. But when you met the committee, we were very alarmed because what is the meaning? Is it that our people are not bringing you health insurance to be treated, or they have health insurance but the conditions that they come with does not need health insurance, or health insurance does not cover, so you put them under non-insured? I want to get that picture clear because it's a bit scary in my opinion. Is it that their insurance have expired and when they got there, then they have to be treated as non-insured? It's a very important information we also need so that we can know what to do. Thank you very much.
Hello, thank you.
I'm the acting director of finance, Richard. I want to respond to your questions. One, you wanted to know the number of months that has been paid or that are in arrears. As I speak now, health insurance is in arrears of 9 months. For 2019, we had January, March, and April. And our submission was up to November 2019. We are in arrears of December submission, December 2019 submission. For the strategies, your question was our debited days vis-a-vis our credited days. We do more on the cash and carry payments to satisfy our suppliers. We try to negotiate with our suppliers for extending the credit days for us. And then austerity measures has been put in place. In that case, we we delay in payment of some honorariums and allowances. Not restore, but we delay in order to satisfy our suppliers to continue service delivery. I want to put it on record that for the co-payments, we at the whole teaching hospital has put a stop to that for the past 2 years. So there is nothing like co-payments as we speak. I think I've addressed those your questions. For the insured on increase, I think the treatment should be for the minor ailment that they bring. That is the malaria cases, the non-complicated ones, might be one of the reasons for that. Thank you. But that's one of the medicals who helped me. Thank you very much.
Yeah, I think when we are talking about when we are talking about the uninsured, somebody could come with a card, but will have to pay for a procedure that is not covered by, or do a lab investigation that is not covered by the health insurance. So you can have very few actually come without a card, but most will come with a card, but the services that they will be offered may not be covered by the health insurance.
Thank you. My question is, with all the presentations, we did not hear anything, or I did not hear anything about traditional medicine or traditional medicine practice. Is it a thing, now that we have a teaching hospital, is it a thing we are leaving behind? Or we have to carry them on? Because if you go to most of our car parks, people sell traditional medicine. Would it be better for us to enroll them and then know exactly the content of medicines that they sell? Thank you.
Right, thank you very much. I have a few comments to make. I think I look at your revenue pattern, and I must say that as a very young teaching hospital, it is relatively impressive compared to where the other young guys started from, Tamale and Cape Coast. Because if you look at your revenue differentials, you seem to be increasing in the area of the non-insured clients. And for me, as I said in my fraternal message, you need to exploit that area and look at your services, because you have to expand that scope. I know some hospitals are now doing about 80%, 90% NHIA, and they are only getting about 10-20% from the non-insured services. But you must be doing about 40-60 now. and therefore there's opportunity for you to scale up in that area. And you also realize that in your diagnostic services, there appear to have been some increments and some drops in specific areas like ultrasound and what have you. My advice is that you have to be very strategic. Even as we are looking at investing in getting cardiothoracic services, you must remind yourself about the area where you are going to, affordability and what have you. So you must be strategic to identify areas where you can invest and get very quick incomes to be able to scale up in your investment in the difficult areas. Because for us as healthcare services, diagnostic services actually is one of our cash baskets. So you must identify those specific areas where you can invest little as a start and begin to make a lot of revenue to enhance your general operations. The other thing is to do with the payments that you made. I must tell you that probably you must even be doing better than some other areas. And it is good that you've been able to negotiate about the payments that you do to the suppliers. We are all doing the same. All the contracts we sign under the procurement law, I think the grace period is supposed to be 90 days. We are all overshooting that. And clearly it's the reason why suppliers for our services is facing all the challenges that we have. I'm happy that we have our honorable MP here and he's sharing in our difficulties. So hopefully when he engages the NHIA or NHIS in 2 weeks' time, I expect a very strong advocacy from him. But it's not just about the regularity of the payments, but also to do with the tariffs. Because you see, the tariffs we are receiving is giving us very little window to execute the kind of mandate we have. Scaling up the specialist services, training, and training cost. All these things do not earn direct money to us, but we've got to spend the service money on them. And research. For all the teaching hospitals, training and research is 2 additional key mandates that we need to create some financial leveraging to be able to execute. And so we need more cash. And as we have indicated, if money is not going to come directly from central government, we should have a certain strategy to ensure that more money is leveraged to take care of that. The bed occupancy for the hospital, I must say, is quite impressive, generally compared to other hospitals. And therefore, I think it is good that you are beginning to think of establishing an A&E to open up and also to look at how to take care of the other services. Mortality. Like we have said, we are always at the receiving end. We are recording the mortalities for all the other facilities. There's supposed to be a national debate. I don't know when we can have it concluded. They're thinking that any mortality happening less than 24 hours, or the person being brought in dead, should not be mortalities being recorded against us, but they should rather be mortalities to be recorded against where the referral is coming from. I think we need to engage on a national debate on it, because that's the only way those facilities can begin to learn that they must refer and refer promptly. Sometimes the patient is being referred when the patient has already begun gasping. And for me, it's not helpful to our health systems. I think I will end here for now. And the challenges, I mean, we will share with you and see how best we can roll out the addresses. Thank you.
I will just give you some comments. I want to dwell on this. I think this one looks like a land use plan and a strategic development plan. In 10 years, government cannot fund this. So how do you go around it? Look at the housing. Once you invest in housing, the people will pay rent. Can we get some housing developers to partner and get the houses? Can we also set up a trust fund and bring people who are endowed as a trust fund? Kolebu has a trust fund where Zoom Lion is on it, Denmark, Magdan, and they come and they raise funds for strategic projects. On their day themselves go and solicit and also add. That one you can set it up using the local, you have a lot of endowed people, and Nanano will support you. And then you look at one of the strategic things to take off. There's one thing I have not seen here, which is an omission. Now, most hospitals are judged by the car park to be a quality issue. If you build all these things, you don't have a car park, nobody can access any of the facilities there. So you should devote a place for about 400, 500 car park. Nobody builds a mall with that car park, just like a hospital. You need customers, a place for them to park, lorry station, and that kind of thing. And they'll pay. Everything is going to be BOT, build, own, operate, transfer. So people will invest. My commendation once again is to the best performance of this hospital lifetime in 2016. Can we scale up and reach 2016 before we can launch to the sky? Because everything in 2016 was the best. OPD attendance, what did they do right? What went right there? And now what are we not doing? The other thing is that you need a lot of doctors. But certainly you don't need surgeons. When you have a surgeon who is operating 1.5 times a week, why should somebody from Kolebu move here to come and sleep? What are the problems confronting the surgeries not being done? Is it anesthesia? Let's talk about it. Is it ICU? Is it theater space? Or is it laziness? Or non-availability? Or they start funding the patients somewhere? Because you can't tell me that 77 per surgeon for the whole year. And if you have 52 weeks in a year. So you understand? When Dr. Makarim will tell you, they don't sleep in Kolebu. They are on their feet all the time. So people must be working. And other than that, you are the CEO. I cannot support you when we are sharing surgeons and I show my data and show yours. They will say, oh, you don't need surgeon. But you need. Let's find out what is happening. But I want to also believe that if you are saying doctor-patient ratio, you are using payroll, nominal row, or timetable. When the number of residents begin to increase, people come from Ghana SFA, they are not on your payroll, but they will be seeing patients. In Kolebu, for instance, we don't take medical officers. Everybody there comes from somewhere to come and do training. But they attend OPD, okay, but we don't use them as nominal. They are not on payroll. So we should find an indicator for that. A common indicator to use. Is it a timetable, number of doctors in the hospital, or number of doctors on our payroll? If you use payroll, it means that those on steady leave will all be part of it. And I think let's do that. My final thing will be, I think there was something that I wanted. The cash cows. There's something in management of hospital called the business of medicine. We are public, but there are cash cow that you can pluck. They are low-hanging fruits. You can pluck them, and the money will be coming. My friend talked about how much is the ultrasound? $5,000. Get 4 of them, $20,000, and they will pay themselves within 3 months. Those things, I think, quickly, it's an investment. Laboratory, X-ray, these are And one MRI can buy 200 of all these things I'm talking about. So before you move to CT, MRI, let's have the low-hanging fruits available, because when you have about 10 ultrasound, you have sonographers coming, even people who patronize it. And the diagnostic services is also linked to your the A&E average length of stay. If people are in the emergency and cannot be diagnosed in time to be moved to the ward, they stay there. So it is a vicious cycle, isn't it? So you find a way of making sure that the doctor diagnoses them properly and move them. If your X-ray is not working, your lab is not working, CT is not working, ultrasound, somebody is not available, then the people stay there. It doesn't mean that the place is getting choked. You are choking the place. Thank you very much.
Can I? Yes. Who is only 10, who teaching hospital is only 10 months old, but your activities doesn't prove so. It looks like you are much older. The CEO already told us in his speech that they are not going to repeat the mistakes of their seniors. And we are seeing it in this plan. This is disabusing the minds people, or the racial statement people always make about black people, that no average black man plans beyond 2 years. This is 10 years plan you have drawn. So it means you are already focused from the beginning. And once you are focused, you are not going to depend on donor agencies to dictate to you which direction to go. That one has no future. This, if you focus, once you have a plan, then if they give you money, you know where the money should go. But if they give you money without a plan, I tell you, you will misuse it and there will be no history. We'll expect that you stay focused, and next year during the performance review, you tell us which part of this project you have been able to carry out. And in that case, we'll emulate, we'll follow you. Thank you very much.
Thank you very much. I think I will start from down, going up, starting from Dr. Abbas's comment. Actually, this is a plan that we are looking to fulfill in the next 15, 20 years. We have met, I think 2 weeks ago, we met investors, because we don't expect that the government will give us this money. And then what we agreed on is that we should break it into years. And based on that, we'll start financing it year after year. We talked about as the emergency, like he said. We have gone very far, and if things prove well, most likely this year it will take off. With the plan, we are looking at accommodation. If you're able to get 2-3 flats, they will pay, and that payment will also support the clinical side from growing, obviously with support from investors. We talked about the difficulties with the surgeons and so on and so forth. I think it's something we have discussed. And we have realized that we have enough space, but the surgeon will not operate without a nurse. The surgeon will not operate without an anesthetist. So that is the missing link. And that is something that we are working on, and we are hoping that we'll be able to get it going this year. With the diagnostics, like you rightly said, space was a problem, human resource was a problem. So somewhere next week, we are likely to, we've prepared a room, an additional ultrasound will be fixed there, and that is going to solve this problem. The lab was also limited, also basically based on human resource. We had additional 9 biomedical scientists and 13 technicians. So we have agreed with the lab that we're not doing proper 24 hours. because they weren't there. So we are going to do 24 hours, and we are going to expand the services, and that will start from 1st April. So all these things are things that we've worked on, and we are hoping that they will take off. I think Dr. Oheneba talked about the revenue mobilization. He talked positive, and I think that that is one of the very difficult areas. Dr. Asari talked about 2016 being our best year. It is exactly so. So because, you know, you are dealing with the same number of people. And as of 2016, our NHIS card holders represented 98.2%. That means that we had 1.8% cash and carry patients. But what is important is the services that you introduce. That will bring in additional income. So that was basically what we're working on. Togbe said something about traditional medicine. I think that it wasn't well talked about here. And I think because of the angle from which we're doing the presentation, the focus was much more on the strategic plan and then the health sector plans. And this doesn't really sound very well there. But to say that, I think it is one of the areas we are really improving. And this year, September, come September, the University of Health and Allied Science is starting a whole department. And so the staff of the department are going to contribute. And I think just last week they supported us with a donation of herbal medicine for us to go on. So that area to where we are giving a lot of attention. It's not going to fade off.
Before we continue, I'd like to acknowledge the presence of some personalities. We have DSP Nelson Gagakuma of the prison service in our midst. He came with some other members of his team. We also have DO3 Ernest Eko, representing the regional commander of the Ghana National Fire Service in our midst. So we'll continue with the questions and comments.
Thank you, but I wish I direct my question to Dr. Heniba. He's just gone out. Yes, thank you for the opportunity. Our First Lady, our Honorable Her Excellency Mrs. Akufo-Addo, took up a project, did it less than 1 year in Kumasi. And I made an appeal to her when she was in Ho. I never heard anything. I wish Dr. Heniba will direct us, because I see her concentrating so much on Konfanoche Hospital, teaching hospital. This is one of the baby hospitals, and we wish the First Lady comes to the aid of our beautiful young hospital here. So I want Dr. Heniba to direct us, especially me, how to go about it. Thank you. That is all my question.
I think the baby and child unit in Kofanochi was the pioneer. After building that, he realized that Kolebu one was worse. So he came back, and then we approached her and said that you've gone to Kumasi, done this nice thing, come and see Kolebu. In fact, they couldn't enter. So we had to demolish, and then within 6-7 months, we have a brand new, bigger than that of Kolebu. But as I speak to you, Cape Coast, they didn't have. Theirs is even worse. So their board chairperson, Nana Prajinsem, went to the First Lady. And when we were here, they called that they want to have a discussion with the chief executive. That's why he's gone. So somebody must go and make a business case to the lady, because there are so many things on the man now. He's building a Teshi market, this market here. So somebody must go there and say that, and tell them with the statistics that look, the babies are dying. Who your baby also needs it. They will program it.
Yeah.
So right. Other than that, now I think they are going to focus on political things.
And I think, Dr. Asare, maybe I can add. You know, Mama, when they built for Kolebu, we happened to be there at the inauguration. And Dr. Asare introduced us to the First Lady. So what she said was that she was going to give attention to Cape Coast. When Cape Coast is done, then she will consider us. So it's something with his help we are following up. It's not that we are left completely out. But Mama, your push is still needed.
I want to acknowledge the presence of Mr. Bafo Bonnie Enoch of Tobinco Pharmaceuticals, as well as Mr. Owusu Mensah Frederick, also of Tobinco Pharmaceuticals in our midst. We'll continue with the questions.
Yeah, may I ask Dr. Tampori? Some of us, we know that in every family, you have an elderly person who will advise. Why is it that up to now, there's no board being constituted for these problems to be solved through them? Because we could just hear that a board chairman of a region managed and got nearer to Her Excellency for, a help. So we'd like to hear from him. Thank you.
Any other question?
Thank you, Togwe. Okay. Kick it.
Thank you, Nana Chair. I thank you very much. Simon, thank you for the good work. I see this pictorial thing very impressive. But what I did not see in the presentation is how you are going to fund it. Throughout your presentation, I did not see any resource mobilization strategy, which is key. It's nice to have this, but if you don't show us, but I take consolation from the Chief Executive's word that you are going to break it year by year. So I'm proposing that each year you should show us how much it will cost and then how you are going to fund it. My next one is about the NHIA. I think Honorable MP made a point, and as a person who compiles the National Health Account, the out-of-pocket is increasing for some time now. And if I heard you right, you said inpatients, IGF, people are not coming. But the government strategy is to reduce out-of-pocket. And this is not to only you, but to all the agencies. We are trying to investigate, but the answers given here shows that we don't take, any money under the table or stuff like that. So, but you are fully funded by government. So my understanding is that you should have a lot of NHIS people coming to you, irrespective of, because they don't care whether you are being paid or not. They have the card and they must assess the health. But your trend shows that the gap is increasing. Can you be honest and tell us exactly what is going on? Because from the policy perspective, it's very interesting to me. The next one is the review of the development of your strategic plan. I think that the other teaching hospitals may have strategic plan, but you don't have. And so you may need to do the preparatory work and wait for a while and take advantage of the completion of the universal health coverage roadmap that is being developed. And then next year, I know it will start this year, but it will end next year. The ministry will develop a new medium-term plan so that you can really align your things to it. Your plan to it. On your revenue, you just gave us the graph. how much you earned, but I would love to see the expenditure drivers, the efficiency gains you are making in the next presentation, so that we know which areas are generating, which areas are consuming and not generating. Thank you very much.
Okay, I assume yours was just an advice. Am I right? Yeah. Then we'll come to Togo. I think that is an interesting question. This question should actually go to the member of parliament here. But I think there were issues that caused the delay. You know, the law itself was being reviewed. And I think it's somewhere 2 weeks ago that the new law came out. Just about 2 weeks ago, where the law was actually approved and we've been given copies. So we are hoping that, because the explanation the ministers made was that he didn't want to create a board and you get some members out after a few months. Because the new one is reviewing the membership of the board. So he wanted to wait with ours. When the law is finished, then all the other hospitals will have new boards formed. So I think we will follow up and see. But obviously, if our member of parliament who happens to work in the health select committee will take it up and help us.
Thank you very much. I think I've been caught on the spot on. I'm happy. The CEOs were with us in Koforidua to help us look at the law, the section 37 or I of the Act 525 of the Ghana House Service and Teaching Hospitals Act. It's really had to do with the composition of the Teaching Hospitals Board. We were able to conclude. The bill was brought to the House. The committee reviewed it, accepted all the proposals you made, and the bill has been passed. The president has assented to it, and I believe we've all been given copies by now. So after the budget hearing, we had a chat with the minister, and you can agree with me. We are in a certain season, and the season is not giving them some time. But I will convey this message to my leader of the committee, Dr. Nuama, and my ranking, that this is creating challenges for your work. In fact, without the board, I'm wondering how certain decisions can be made. And as such, as soon as possible, the minister should do something about the composition of the board for the teaching hospitals.
And then so that they can take care of the economies in that area. At the same time, we are encouraging them to open polyclinics with deals with primary cases. Looking ahead, what should teaching hospitals be doing? Should they be looking at primary cases? Should they be looking at specialist cases? I think it's something that we need to know. The other thing I would like to know is that when working with the teaching hospitals on indicators, we realize that standards, when we're trying to set targets, we realize that the standards are not available. It's difficult to assess performances when the standards are not there. So I think going forward, the teaching hospitals should come together and start looking at standards. We cannot depend wholly on international standards because our situation here is unique. So we must have our own unique standards which we can use to determine whether we are making progress or not. So these are the two interventions I'd like to make. Thank you very much.
Any other question or comment?
Thank you. I must say that I've really enjoyed proceedings this far, and I'll commend again the management team for good work done. I'm really just a bit worried about the post prophylaxis, exposure prophylaxis that you had, especially for your own staff. It seemed to have been a bit high and needs to be looked at carefully. So I would want to find out if there's any strategy to address that, because the reason was that new recruited staff members had this problem. So could we make sure that we prevent it? Because we're now talking of preventive medicine as well, even within the teaching hospital situation. The other thing that I want to say that because of we have this issue, once it's a teaching hospital, postgraduate training is so crucial. And to have that, you need to, it helps a lot with even shortage of staff at the medical school level, because most residents will do the teaching. So if you have staff gaps in the medical school, the residency training fills that gap somehow, and it's very helpful. They do a lot of the teaching, say that the consultants can do other things as well. I'm talking this because I happen to be part of the University Council, and I know the challenges we face in recruiting. You just talked of pediatricians and so on, in recruiting even lecturers. But if you have some kind of postgraduate training, it helps fill that gap. On this note, I would say that if you appeal to Ghana College, different faculties, because Dr. Moy was here, he's talked to me. I happen to be also part of the faculty for Ghana College. So ideally, teaching hospitals shouldn't have residents come on rotation here. They should rather send out. But we have arranged to get some residents to rotate here, filling the gap as you try to get your own residents. Thank you.
Thank you so much. I want to plead with management that almost 3 months of delayed in submission of NHIS claims is not healthy, because it will affect payments. NHIS paid based on badges. Badges are created based on submission. So if you are in arrears almost 3 months, it means that your payment will also delay. So we want to plead that even though payments are delaying, we shouldn't help again by delaying it further. Other than that, there will be challenge. Number two that I want to say is that when you refer to insured and non-insured, definitely as a teaching hospital, your non-insured will be increasing so long as you are introducing specialized cases. And the non-insured doesn't mean that the person is not having health insurance. But the service that the person is coming for is not insured. So when we see the graph indicating that the non-insured is increasing, it doesn't mean that people are no more using the health insurance. But the fact is that you are now introducing specialized cases, and there's the need for people to assess it. Thank you so much.
Thank you. I want to respond to the delay in submission of the claims. I said we submit up to November. December we move to polyclinic. The claims are ready, but we have to get the accreditation or credentialing for the primary health care for the polyclinic. So we have been talking. Even yesterday we were in Accra for that certificate to be given, so that we can use the CC code for the claims. So not that we are delaying, we are on time. We are the best institution that submit claims on time. That's one I can vouch for it.
Chief Executive, I'm advising you to rename the polyclinic primary care or family center, because the tariff for polyclinic is very low as compared to that of family medicine center or primary care center. And in polyclinic, you can't even feed. When you feed, they won't pay because you are not supposed to feed. So change the name. If you have taken the form for registration, change the name from polyclinic. Kolebu Polyclinic, long time. They were being underpaid. Until when I went there, we changed the name, and the money has started rising. So.
Thank you very much. With that being our last question and comment, we'll move on to our chairman to take the chairman's closing remarks.
Thank you, MC. My remarks will be very brief, so if you don't pay attention, you may not hear it. I think the exercise just point to the fact that in everything you do, there's an account to give. And after listening to the various accounts that has been given, I think the watchword is in everything we do, we should make sure we sacrifice. And we have seen that the teaching hospital has sacrificed a lot. I would take what I have heard to my paramount chief, Togbe Apede the 14th, and inform him about some of the things that you need in the hospital, especially about your development plan. Thank you, and God bless you for your cooperation.
Much, Mr. Chairman. Shall we take the vote of thanks from Ms. Bridget Jagger?
Thank you very much, MC. I'm very honored to be here to give the vote of thanks for this August occasion. Our most gratitude goes to the Almighty for giving us the opportunity to be here and having a successful program. We would also like to acknowledge the presence of our chair for steering the occasion and making it successful. We would also like to acknowledge the presence of our guests of honor, Honorable Dr. Archibald Lecha, Togbio Mamao, Member of Parliament, Acting CEO, Directors and staff of HTH, CEOs and directors of our sister teaching hospitals present here, Vice Chancellor and staff of UHAS, head of religious bodies in our midst, representatives from various security agencies, friends from the media, all invited guests, ladies and gentlemen. On behalf of the whole teaching hospital, I would like to say a big thank you to you all for honoring our invitation and making this program a successful one. We would also like to thank our special guests for the continuous support and the new promises being made to help bring up our facility to standard. Would also thank you, and we hope that we'll get more support from you. Akpena Mikata, thank you.
On that note, let's invite Reverend Father Samuel Bobodu to give us the closing prayer. Shall we be on our feet, please? Before the closing prayer, please take cognizance of this announcement. From here, we'll be moving down for lunch. The high tables will move out as we did the first time, and the rest of the population will go to the pool side for our lunch. We'll also be taking group pictures right after here, so let's take cognizance of that.
We pray in the name of the Father, and of the Son, and of the Holy Spirit. Amen. Lord, as we come to the end of this meeting, we want to give honor to you. Thank you, God, for the time we had together to discuss issues and make decisions that would improve health delivery in our country. Bless each person who took the time to be present here today, and let your hand of protection be upon us. Let the work done here today come to fruition, and let it be for your greater glory. Help each of us to do our part to bring the plans discussed to life. As we leave this place, surround us with your love. May we find the comfort we desire in you and the strength we need in your name. May your joy be our strength when times are hard, and may your presence be the peace that overflows in our lives. Grant us traveling mercies that we may reach our various destinations safely. And may the Almighty God bless, guide, and protect you as you go on your way, in the name of the Father, and of the Son, and of the Holy Spirit. Amen.
So we'll be taking the photographs immediately downstairs, just in front of the reception. So please, let's move downstairs and take the photographs before lunch. Thank you.